Institute of Postgraduate Medical Education and Research, Puducherry, Karaikal campus. Now I hand over the session to Dr. Saranya Ma'am, Associate Professor, Officer in Charge, Anatomy, JIPMER, Karaikal, to talk about the measures taken for voluntary whole body donation program.
Thank you, Dr. Ambika. So we had some questions yesterday in the chat box related to measures taken for body donation program. Excuse me. So that is like this is a budding institution, our Institute of JIPMER Karaikal. We just started in 2017 and we moved on to the new academic building in the last year in the 2023 actually. So then we slowly started procuring the necessary equipments for the newer academic block. Parallelly, we had to also take initiatives to start procuring the cadavers for our own teaching and learning purposes. So we tried to approach all the local administrative authorities who can help us to procure the cadavers. We all know that there are three sources through which we can procure the cadavers bodies for ourselves. So that is the main sole important source is the voluntary whole body donation, and then the two other sources are when we get a donated body from individual who is dying in the hospital, the relatives when they decide to donate, or in instances when we get intimation from the police of about an unclaimed body. So to initiate all these angles of getting the bodies for our anatomy department, we tried to approach initially the hospital that is attached to us. Our institution don't have a individual hospital for our own yet. So we are tied up with the Government General Hospital of Karaikal. So we met the administrative authorities of Government General Hospital, Medical Superintendent of GH, Dr. Kannaki Madam, and Dr. Parthiba Vijayan. He is a resident medical officer of GH. So we sought their help to consider donating, or if there is any option of donating the bodies which is come from police authorities through unclaimed bodies. In such situations, so those bodies were considered to be given to the institute of our institute. So that time, if there is not any foul play, the police try to identify the individual's origin. Like one time there was an incident where the body which was received was an unclaimed body initially. Then after intimation in 72 hours, they got to trace the identity. But the relatives who were proven to be the blood related of the deceased, they actually were not interested to take the body back home, and they said that then when they came to know about this option of body donation program, then they accepted to donate the body with all the legal formalities. So in that way, when we approached the police department and the government general hospital, we were able to get a source to procure one body for ourselves. So then also we know that the main important and a legal way to procure the bodies is always the voluntary whole body donation. So that will not happen with in few days or months. It will take a very long time for us to set into the process and to see the outcome of the program. So we actually started approaching all the stakeholders for us. We actually went to old age home, and we have got an appointment in the next 2 weeks to give the awareness program in the old age homes that are nearby. And we also approached the youngsters in the surrounding other colleges of our district. So all the youngsters, we gave the awareness talk. We played the videos related to the awareness of voluntary whole body
Recording in
donation.
progress.
And we also conducted some competitions like poster painting and slogan writing competitions among the students of the neighboring colleges. And so that by this means, in this age itself, they are able to be aware of such a program. And we believe that many of them will go and convey the message to their parents or old age people. So in this way, we approached all the age groups, and we in the middle age group, we have a plan in the next week to reach the rural health centers and to initiate the voluntary whole body donation awareness program. We have actually taken prior discussions with the Anganwadi workers and the social workers in the rural districts which are nearby our institution. So I believe through all this social outreach activities, whenever we are reaching the public in person, and we are trying to explain and make them aware of about this voluntary whole body donation. So if not at the moment, later they may think about this, and when they talk about this to the surrounding people, somebody who is interested, this will be at least stored somewhere in the back of their mind, and one day they may come forward to pledge their bodies. So these are all the activities which we have initiated. And now after such measures that we have taken, we are now started getting our registrations for voluntary whole body donation. And of the last resort, I thought like this is one thing I want to share to the audience, where I tried to approach the municipal corporation of Karaikal district, and we met the commissioner of municipal department, and there also we tried to explain and gave them an awareness talk on voluntary whole body donation. And we at the moment, why we reach the municipal department is where all the public will finally have to go after any death in the family. They have to go to the municipal department to get the clearance for cremation or for the further proceeding. So for the disposal of the body, they need to get a clearance there. So they will go there. So at that time, when they are reaching there, if there is an option that where the public is coming to know about the option of donating the bodies to the cause of scientific growth, then they may consider at any point of time. So this is the reason why we thought we may approach the municipal department also. So the people who are dealing with the public to give the cremation permission certificates, they are also educated and taught about the voluntary whole body donation program. So now for us, the municipality sanitary manager, he is now aware. He is the one who is contacted by the public to get the cremation certificate. There are some instances where sometimes very in very poor situations, the public may say that we don't even have uh, enough money to cremate the bodies. There are situations which, when this has happened, and the municipal people themselves have helped them to cremate. So these are the situations. I'm not trying to say that we are trying to grab the opportunity or so, but sometimes they also feel happy that at least we have donated the body of my kin for a good cause. So they feel a little bit contented about the act when they do it at the end. So, and we have given a token of appreciation to the relatives of the person who has donated the body. So all these are the channels through which we may try to get the bodies for our academic purposes by voluntary means. So that is always the better way, rather than trying to procure through the unclaimed bodies. So in this regard, our students of JIPMER Karaikal, first MBBS students, have created a voluntary whole body donation awareness video, which we whenever we approach the public or the students, wherever we go, we play this video, and then they get a little bit sensitized, and further they try to ask their queries, and we had a discussion among the public, and further we started getting more and more registrations for voluntary whole body donation. So, and I request our IT team to kindly play the video on voluntary whole body donation. After this, our first session will start. Thank you. We are sorry for the technical glitch. So I think we may start the session. We can proceed with the scientific presentation. We will play the video afterwards, sometime later. Now I hand over the mic to Dr. Ambika to proceed with the session.
A very good morning to one and all. I welcome you all for the day 2 of the National CME on the journey of the anatomical gift, procurement to ultimate utilization, organized by Departments of Anatomy and Forensic Medicine and Toxicology, JIPMER Puducherry, Karaikal campus. We will move on to the sessions for today. I would like to welcome Dr. Saranya ma'am, Associate Professor, Officer in Charge, Anatomy, JIPMER Karaikal, to introduce our first speaker for the session, Dr. Ashika sir.
Thank you, Dr. Ambika. So it is my immense pleasure to introduce our distinguished guest speaker, Dr. Rajshekhar sir. Sir is currently serving as additional professor in Department of Anatomy at JIPMER Puducherry. Sir has over 15 years of hands-on experience in embalming, having handled more than 120 cases. Dr. Rajshekhar sir is a prolific researcher with 50 plus publications and an H-index of 9 with over 200 citations, actively leading multiple ongoing research projects. His groundbreaking work on soft embalming using Genelin earned him his prestigious Best Research Publication Award with a prize of 1 lakh. He is also the author of valuable resource book, Embalming and Voluntary Whole Body Donation, which is actually the main guide for most of the budding institutions now. He is actively involved in scholarly activities, holding editorial roles in National Journal of Clinical Anatomy and JAM, and peer reviewing for Anatomical Sciences Education and BMJ journals. Above all, Dr. Rajshekhar sir is the guiding force and main mentor behind this National CME. Actually, sir, not only for this National ECME, but also for every step of the JIPMER Karaikal, you have been a backbone for us, sir. We hold sir in high regard for his humility, soft-spoken nature, remarkable patience, and respectful demeanor. Sir is admired for his rich vocabulary and his impeccable command of English. We are truly honored to have him with us today. I invited Dr. Rajshekhar sir to deliver his talk on soft embalming. Over to you, sir.
A very video. This is a video of a surgical skill training workshop where the surgeons are trying to learn laparoscopic surgical skill training for an intestinal surgery. We can see the laparoscopic instruments here, and we will also see the gut and the texture of the gut. So I would like everybody to keenly observe how the gut and how the peritoneum is, and we have to have this mental picture and compare that with what we see in formaldehyde embalmed bodies. And I'm going to actually cut off my video so that there won't be any disruption in the talk. So this video actually shows us and impresses us upon two things. One is the need for soft embalmed cadavers. You have seen how the surgeons are struggling to hold the needle with the laparoscopic instruments. So this actually brings us back to the importance of the need for having this cadaveric workshops and the soft embalmed cadavers for those workshops. That is first point. Second point is, if you can compare the stomach of this video and the stomach of the formalin embalmed cadaver, there'll be a huge difference. And you would have also seen how the greater omentum, the texture of greater omentum is. So this is actually one of the soft embalmed cadaver that we had in JIPMER. In JIPMER, we also have the experience of conducting soft embalming and surgical skill training workshops in various fields like gastroenterology, obstetrics, gynecology, plastic surgery, and so on and so forth. And with this credentials, I would like to go forward and present this topic of soft embalming. So today, in today's lecture, we'll be seeing the why we do this soft embalming and what are the various types of soft embalming solutions and different steps involved in soft embalming. And also we'll be trying to see certain best work practices for getting best results. We have seen the definitions of embalming yesterday in Dr. Saranya's session, but briefly, it's a process of preservation which fixes these components like proteins, carbohydrates, and lipids, and it would only postpone the decomposition but not entirely stop the decomposition. Which one is the best preservative? We all know that it is formalin, and it gives us long-term preservation and excellent disinfection with the best of histological results. But there are certain problems. And before going to the problems, we'll try to see how this formalin acts and gives best results. So this schematic shows us how formalin acts. The one to this side, what we have is a mechanism that is called as cross-linking mechanism. So this is formaldehyde, and it actually exists in methylene glycol form. It actually releases this methylene, which actually forms bridges between certain amino acids. Sorry for that. So which actually forms bridges. This methylene actually forms bridges between amino acids. And these bridges, they join together and form a scaffolding of proteins so that the tissue becomes very strong and hard. So this is called cross-linking mechanism of formalin. Formalin also preserves the tissues by one more mechanism that is seen on this side. What it does is it actually binds with the water molecule and it displaces H plus and OH ions and thereby removes the water molecules from the proteins. So water molecule actually forms a shell-like arrangement around the protein, and that shell is removed so that each protein molecule comes into contact with the other one and binds together. So these are the two mechanisms followed by the formalin for fixation. And here what we have to observe is it is removing water molecules. That means it is causing dehydration. And that is the reason why the formalin embalmed tissues are mildly dehydrated. Okay. So therefore that stiffness. And even though formalin does this thing, formalin primarily does this action, that is the cross-linking of proteins between the amino acids. And this is actually called as coagulation technique, and this is primarily done by alcohols, and this cross-linking is primarily done by formalin. Now we have seen that formalin forms bridges, that is that methylene bridges, and these methylene bridges are formed between various amino acids. Formalin, when used in lower concentration, it forms these bridges, which are very, very weak bridges and are reversible bonds. Therefore, they'll be vulnerable for acid hydrolysis. That means if we are trying to keep the tissues in water, the bonds that are formed might be reversible. So that means the bonds are not so strong. But when formalin is used in higher concentration, lysine and tyrosine bonds are formed, and these are very stable and acid resistant. Therefore, this tissues, the higher concentration tissues, stay more preserved and for a longer duration when compared to the lower concentration. So here the bonds are weaker and the bonds are reversible. So that's what we have to understand. Because the bonds are very strong in formalin, it gives off a lot of disadvantages, like very hard tissues, stiff joints, and inelastic tissues, and which are all actually impediments for doing this cadaveric workshops. Therefore, there is a need for this soft embalmed cadavers for practicing various surgical skills before the patients are operated upon. And we also need this soft embalmed cadavers not only for practicing skills, but also for designing biomedical equipment so that a better biomedical equipment is designed which actually fits the live person. The need for soft embalmed cadavers was also felt by many surgeons in various fields. Example, somebody has observed that learning of flap rising and performing the first anastomosis in clinical cases lead to high risk of flap loss, and free tissue transfer is often reserved for experienced surgeons. So this impresses upon the need for practice before going for that flap raising surgery. And it is also observed that in formalin cadavers, it's very difficult to create pneumoperitoneum, which is essential for laparoscopic surgery. So because of this felt need, we have this soft embalming. If we compare the goals between the formalin and soft embalming, or anatomical and soft embalming, they are actually diametrically opposite. So in case of anatomical embalming, the preservation and the bacterial and fungi disinfection takes primary role, and the lifelike appearance and flexibility takes the backseat. But in case of soft embalming, the lifelike appearance and feeling and dissection as if we are doing it in a patient, that takes the precedence over this antimicrobial action of this. That is also important, but that is not the primary goal. So to achieve this soft embalming, we have various options, and going through all the options will be beyond the time limit of this lecture. Therefore, we will be seeing only few practical options that you can try to implement at your institution. So to start off with, we will start with fresh frozen cadaver. I will briefly touch upon this because we have a separate session on this. So it is actually considered as an unembalmed benchmark because it is the most closest to a lifelike body. It consists of various steps, and it starts off with a step called as irrigation, where we empty the blood vessels, and then we actually freeze the body in minus 20 degrees. After that, we thaw the body whenever there is a need for this workshop, and this thawing will take somewhere around 24 to 48 hours. Usually it will take more than 24 hours, and that would be followed by any arterial infusion such as dyes based on the procedure that is required. The advantages of this technique is that it is as much as lifelike as possible, and it is the best thing what you can have for surgical skill training. And it also has certain disadvantages, such as it is only suitable for a single day procedures, and it is unsuitable for a 2-day procedure, because as soon as we take out the body from the cold storage, rapid decomposition will start. And we also have another disadvantage in that it needs a large capacity freezer which maintains the body at minus 20 degrees from the time of procurement till the time of utilization. The freezer need to run, okay, and it will incur a lot of electricity bill. And there is also this risk of infection because we are not introducing any disinfectant solutions. Therefore, we will have this risk of infections. But if we see the outcome of this technique, it is the best for any surgery which is intended, and it is also good for especially vascular procedures where the minute test of the blood vessels are required to be patent. So since we did not introduce any fixative, there is no clotting of blood, and we washed off the blood using saline irrigation before we put the body into the freezer. Therefore, all the vessels are presumed to be empty and ready for taking up any sort of dye that we inject into the body. So that is about fresh frozen cadaver. Next is Thiel's embalming. You might be aware that Thiel's embalming is the gold standard of soft embalming, and it consists of two types of solutions: stem A solution and stem B solution. Stem A consists of some antibiotics and some humectants and tissue stabilizers and fixatives. But this tissue stabilizer is very important to note because it is the component that is used in preparation of explosives. Therefore, procuring this ammonium nitrate is very, very challenging. So stem solution B also has certain other humectants and tissue disinfectants, and these two mixtures are actually combined. When we are procuring this ammonium nitrate, we have to be very careful because the place where we store this ammonium nitrate is also important. We have to make sure that that room does not even have a power point, a power plug or a switch or anything. So this is a image or a video showing the storage of ammonium nitrate gone wrong in a country called Lebanon and its capital Beirut. So this ammonium nitrate was present in a container, a shipping container, and it was not attended to properly. Care was not taken to store it properly, and this has led to a huge explosion. Once we prepare the solution A and solution B, we add a little bit of formalin to that and some salts and prepare a final working solution. We will also see the immersion fluid of Thiels. It has some humectants, a little bit of formalin, and some antimicrobial and some stem solution. Once again, even the immersion fluid also has this ammonium nitrate. And this is the final composition of this immersion solution. So the procedure goes like this. On the first day, we start off with arterial injection, which is very, very slow. And we inject for some time and we give a break for some time. Once again, we start injecting and we give a break. Why we do this is, once we start injecting, the body actually swells up. And we give some break so that once again, the body comes back to a normal posture from that swollen position. So that this has to be done in cycles. And this is the day one procedure. And after the day one, we actually place the body in a airtight plastic body bag and we put it in cold storage. On the day two also, we do the same slow periodic arterial injection to saturate the arterial compartment as well as the capillary bed. Now, venous compartment is actually empty because this fluid actually has a lot of viscosity and density. Therefore, the venous percolation will be very poor. So, to compensate for that, we have to inject the veins also using this arterial solution. Followed by that, we have to inject the cavities and we should also inject the intrathecally. So that is the inside the meninges we have to inject. After these injections, we will store the body in the immersion solution, and literature varies regarding the storage period. Some publications have told that storing of 6 weeks is enough. Some publications say that storing of 6 months is required. And in between, we should also look for any fungal growth in the tank. So if you see the advantages of Thiel's embalming, it has unmatched tissue pliability and realism. This is as good as it gets. So it has the most flexible joints and pliable tissue. Here we have to note that the flexibility of joints is too much that it will be good for orthopedic surgery, but then it will be bad for biomedical examination because it actually increases the normal range of the joint. Say, for example, if a joint is extendable 100 degrees in a normal human being. So this tissue actually increases that extendability to 110 degrees. So that is actually not normal. So it is that flexible. Next, if you see the disadvantage, it's a very complex technique, the most complex technique like we have seen. It is a 2-day injection procedure. It consists of intrathecal cavity injection and venous injection. And to do all these things, we need a lot of time, expertise, and technicians, trained technicians to help us. And we are aware of that this risk posed by the ammonium nitrate solution that we are required to store this in a fireproof room. Next is cost. It's very, very costly, and being a toxic chemical, it is actually required to be disposed, whatever the chemical that is coming out from or leaking from the site of embalming, that waste liquid should be disposed by a special service. These are people who handle hazardous material. So we have to hire them. And they charge for that disposal of toxic chemicals. So these are some disadvantages. And there is a variable shelf life for this cadavers. Once again, the literature varies from 3 months to 3 years of storage. Uses, if we see for heels, it is practically used for all the surgeries that we can think of, except for biomechanical testing of biomedical devices. Next one will be the saturated salt solution, otherwise called as Coleman solution. This is the most cheapest of soft embalming solutions, very cost effective and low toxicity. This advantage is because of the use of maximum of sodium chloride as a fixative. The sodium chloride or common salt will act as a fixative, but then it will be assisted by some amount of formalin also. And here the phenol takes care of the antibiotic and antibacterial function along with the help from alcohol, while the glycerin gives the humectant properties to the tissue. So after the arterial injection, we have two options to store this saturated salt solution body. One is to immerse the body in the tank containing fluid, which is same as the arterial fluid. And the other option is putting it in a plastic body bag, sealing it off and storing it in cold storage. So once the body is injected, we have to wait for 1 year for the body to settle down, and then only after 1 year, it will be ready for use. In the meantime, since a lot of salt is involved, we have to have the cadaver in a moist condition. Otherwise, it will become very dried and it becomes like desiccated, just like a dried fish. We have certain advantages of being low cost and low toxic option, but then it has huge disadvantages in that once we take out the body from the cold storage, it rapidly deteriorates. That is, the decomposition starts very quickly. Not only that, the antimicrobial effect in this solution is not adequate enough. Therefore, the people handling this cadavers are at the risk of getting infection from these two very dangerous bacteria, that is the Clostridium perfringens and Pseudomonas aeruginosa. So once again, this brings us to the question of the antimicrobial effect or antibacterial effect of this saturated salt solution. Apart from that, if you see the tissues, they immediately after embalming, they appear edematous and waterlogged. And over a period of time, the skin also loses its color and becomes very, very pale. Then once the body is taken out and started using, it also has this observation, that is the salt sedimentation. Some open areas where the tissues are seen, we can see some salt sedimentation on the tissues, and it will also have this corrosive action because of the presence of salt. So it corrodes the tables that are lodging this cadaver. Next one is this N-vinyl pyrrolidone technique. This is a Japanese technique. It is a very costly technique. It's a very new technique. This is the first technique that we are seeing which does not have any formalin. So it is purely handled, the preservative action or fixative action is purely handled by ethanol, 5.8 liters, and the humectant action, that is the softness, the chemical that gives softness, that will be handled by this N-vinyl 2-pyrrolidone. And it is actually a monomer, and it requires one more catalyst to polymerize it so that it forms a plastic kind of a shell around the protein molecules, and these plastic kind of shells will prevent the dehydration of these protein molecules and therefore retain their pliability and plasticity. It comes with different concentrations. We can use the concentration based on the need. We have to inject it arterially. After arterial injection, once again, it has to be stored in a cold storage. And it also has an option of storing at a room temperature if we don't have this cold storage option. It is said to last till 1 year. But there is a very big but for this. It has a huge disadvantage in that it's a confirmed animal carcinogen. It's very, very dangerous to work. and if at all spills over the eye, it causes serious eye damage. And it also, in the nature of being a monomer, it also has this property of badly reacting with plastics. So no polypropylene or no latex gloves should be used, only nitrile gloves should be used, and no plastic tubes should be used. So this actually brings us a lot of practical problems. If no plastic tubes are used, that means we cannot use the plastic tube that comes with the embalming machine. Okay, so that poses a new challenge for us. But when worked out, this gives the best of the quality to the tissues, so much so that the motion physiology of the vocal cords was studied in this NVP embalmed cadavers. Next one is this ethanol glycerin lysoforming technique, which is an alcohol-based technique, and which is more or less more practical technique. It has the primary function of fixation taken care by ethanol, and the humectant action is taken care by glycerol, and the antimicrobial action is taken care by a chemical called as lysoformin. This lysoformin is not available in India. It is somewhat like a Dettol or a Savlon, but then more potent chemical. But when we see the chemical composition of lysoformin, it consists of certain chemicals which are more closer to formalin itself. That is, it has glyoxal, glutaraldehyde, and two more chemicals which are more closer to this formalin. Therefore, it is not strictly a formaldehyde-free solution. This solution also has a need for intermittent arterial injection. That is, we inject for 30 minutes and we break for 20 minutes so that the tissue percolates from within the vessels, within the capillaries, into the capillary bed and interstitial space. Then after that, the arterial channel becomes empty and it will be ready to take up new fluid. After arterial injection, we are required to wrap the body around with a cloth which is drenched in 1% thymol, and this will take care of the superficial surface embalming. And after this wrapping around with the gauze, we put the body in the cold storage. It is said to have a shelf life up to 1 year. There are certain advantages in that it has a very good tissue pliability and low toxicity because it only uses alcohol. And it is also good for multiple uses. That is a very, very important function to have. And it is used in laparoscopy and endoscopy according to the literature, but it has a very, very big disadvantage in that the alcohol content is so huge, therefore it forms a huge flammability risk. Next is, because the alcohol is there, it is actually a coagulating fixative, therefore causes severe dehydration to the tissues. We all know the function of alcohol, which causes dehydration. We use this in histology also. And the preparation of this technique, the body requires to be put in the cold storage for a minimum of 2 months before it is ready for this workshops. And since a lot of alcohol is involved, cost will also go up. If you see this ethanol glycerin lysoforming technique, it actually belongs to a family of soft embalming solutions which primarily use alcohol as the fixative. The other solutions in this family are the ICLSP, that is Imperial College of London soft preservation fluid, and also the phenoxy ethanol, very old fluid, which is studied recently by a person called Crosado, therefore given the name Crosado technique, which is nothing but flowery names given to a common technique that uses ethanol as their primary fixative, ethanol or methanol, that is the alcohol. Then the humectant action is taken care of by this glycerol, and the antimicrobial action is taken care of by various chemicals. So people are playing with different chemicals and changing its name. That is, in case of ethanol glycerin lysoformin, lysoformin is the antimicrobial, Here ICLSP, it's the phenol, and in technique, it is the phenoxyethanol. So phenoxyethanol actually it's a preservative in the sense that it's antibacterial, and it's actually food preservative. It is used to store food and flowers. So it's a very safe technique. Once again, since all of them use alcohol, the cost will go up, the disadvantage of flammability will go up, and the disadvantages of dehydration of the tissue will go up. So it is also the disadvantages of flammability and cost of the technique and dehydration. And we should also be mindful that we should have a good ventilation when we are doing this embalming. Otherwise, people are at the risk of inhalation of this alcohol fumes, and there is also this fire risk. Therefore, the ventilation should be adequate. Next comes another proprietary solution called Genlin embalming, which is cost effective after saturated salt solution. So the cheapest will be the formalin, which we cannot use for soft embalming. Next cheapest will be the saturated salt solution, and this is the third cheapest option, that is the Genlin. Of course, we have this fresh frozen cadaver, which do not use any chemical, which can be considered as a no cost option, but then maintaining a minus 20 degrees freezer is itself a costly affair. So this Genlin is, since being a proprietary solution, it consists of various chemicals which are not fully disclosed. It consists of chemicals which come in these bottles. They are named arterial ultra, arterial enhanced, cavity, and unigram. There's one more chemical called as unigram. So various chemicals like formaldehyde, 1-methoxy 2-propanol. So these various chemicals are used in permutations and combinations in these bottles, and the bottles are chosen, or the fluid is chosen based on the need. Say, for example, the body is severely decomposed, or it is having certain amount of decomposition, arterial ultra is used, and arterial enhance is used if there are no signs of decomposition. And this cavity fluid is also used along with arterial solution in this Indian context, what we are doing in India. Next, after this bottles are mixed together, we have two options. If we have a conservative approach, we can inject 2.5 liters of those chemicals diluted with 5 liters of distilled water, and there is no drainage used. This is the conservative approach. And the non-conservative approach is when we have huge quantities of Genlin, and almost 25 liters of Genlin is used for injecting the body, one body, and this is done usually with venous drainage. So once the arterial injection is done, we store the body in a sealed plastic body bag in a cold chamber, and once in a week we are required to do this, what is called a surface embalming, with a chemical called unigram, that is also supplied by the same Genlin company. So if we see the shelf life, it is shown to be preserved without any major problems from 16 to 18 weeks, according to the what the company claims. But then it is also said to be quite good, usable till up to 8 months of duration. The primary advantages of this technique is that it is very simple technique, user friendly, and more or less cost effective after saturated salt solution. But then we have the risk of Clostridium perfringens and Pseudomonas aeruginosa risks in saturated salt solution. This also has a fast preparation time. So we need the cadaver by tomorrow. We can do it today and use the body tomorrow for the workshop. So the tissues are also demonstrated to be soft and supple. But it has a very big disadvantage in that it's a proprietary solution. Therefore, we don't exactly know what chemicals are used in which proportions. Therefore, we cannot iterate it. So we cannot change it according to our needs. Therefore, standardization of this technique will be challenging according to the temperature of our region, according to the humidity of our region, according to the status of the body, if the body requires a stronger fixative, and it also depends on what is the time delay after the death. So it has been shown to have many uses in a lot of techniques. We primarily use this technique. We have done the workshops that I've shown earlier, and we have got good results. So this is the chemistry part of soft embalming. Now we'll go to the procedure part of the soft embalming. So we'll try to see some best working practices for getting good results. So like with any other embalming, we have this different components of embalming technique. We do arterial, and also certain cases we do venous drainage, followed by cavity embalming of abdominal and cranial cavities, and some inadequate areas requiring additional supplementation, that will be taken care by hypodermic embalming, and the surfaces by surface embalming, followed by a weekly maintenance procedure. That is the ancillary procedures that what we do for maintaining this surface disinfection. So to start off, we actually take up the body, we verify the body documents of the body, we disinfect, we shave and wash. This is how the workflow goes, which is almost similar to the anatomical embalming. But the proof of the pudding, or the devil, is in the detail. So to get the best of the results, we have to have keen observation of the cadaver during examination, during embalming, after embalming, and to certain extent even before embalming. So when we are doing this thing, we should observe, especially during embalming, we should keep on observing. And if we notice any problem, we should plan our primary intervention. And after that intervention, we should see whether the results are working out or not, if the intervention is working out. If not, we have to choose another secondary intervention. We will see what these interventions are. Therefore, after planning, we start off, we verify the documents, we don our PPE, we switch on the air ventilation system, we make the fluid ready, and we also make the embalming station ready, and always try to select the lower pressure and slower speeds when you are aiming for good results in soft embalming. So this is a machine called peristaltic pump that we are using, which is supposed to be the preferred method. And in that, we'll be using very slow infusion, that is of 20 RPM, when we are aiming for soft embalming. Now, once the things are made ready, we put the body on a table, and we do this surface disinfection to start with. We surface disinfect not only the body, but also the orifices and equipment. We can use this solution for surface disinfection. We can use any solution, but better to avoid formalin because it causes burning of eyes. So therefore, this is primarily based on alcohol. After that, after surface disinfection, now we are safe to touch the body, and we will be donning the PPE, but then we are now for touching the body in the sense that we are trying to set the stage for embalming. First step for that is we have to induce the purge. So purge is the secretions coming out of all the natural orifices. We put pressure on the abdominal cavity so that the purge is induced, and any contents of the body are let out, and they can be washed off. So this is better to do now rather than they coming out during the process of arterial injection. Once we do that induction of purge, we wash the body, we shave the body, and we remove any medical devices that they are attached to the body. Then after that, we position the body and try to relieve the rigor mortis. So this step is actually very important, and this step is stressed by Dr. Deepak yesterday also. when we are getting the body immediately after death, we should expect this rigor mortis. When we are getting the body in the rigor mortis, we should be very happy that this rigor mortis has not passed. If you see the signs behind the rigor mortis, when the breathing stops in the Krebs cycle, the lactic acid acidosis happens. Therefore, the body becomes acidic and the muscles goes to spasm, and therefore the rigor mortis. That means the the decomposition has not yet started. This is our first sign. Then we should be very happy that decomposition has not yet started, and it is very good to get the body in this stage of post-mortem. We have to relieve this rigor mortis because it helps in the positioning of the body, but also it helps in the fluid distribution, better fluid distribution. Now, how do you do this relieving of rigor mortis? We slowly and gradually but firmly flex, extend, and rotate the joints. And we do this from proximal joints to the distal joints, starting from shoulder till the joints of hand. And we try to massage the muscles. Once again, I cannot stress this adequately. We should do it very slowly, gradually, but firmly. If we are not mindful of that, if we use excessive force, that may lead to capillary rupture and swelling up of one particular part of the body, which will result in failure of embalming. Not only soft embalming, it will fail. It will result in failure of even the anatomical embalming also. To cater to that, once again, if we notice any such swelling, we have to intervene and do what is called a sectional embalming. That what Dr. Saranya has talked yesterday about. Once we relieve this rigor mortis, we position the body, we elevate the body using the wooden planks so that the less amount of body is in contact with the surface, and the parts which are in contact with the surface, they take up very less fluid. They are not embalmed properly, and this part is embalmed properly. Therefore, we should elevate the body as much as possible using the wooden planks. Then once the arterial injection is completed, we should always supplement this parts with this hypodermic injection. This is important regarding the elevation of head. We usually elevate the head so that too much of fluid does not go into the head and lead to super swelling and tightening of the head, especially when the body is intended for any neck surgeries. Therefore, to obtain the even distribution of the fluid across the body, we usually elevate the head, not to an extent that it falls above the level of the body, but then it should fall at the level of the body, and without the neck support, it falls below the level of the body. Therefore, too much of head swelling will occur. Therefore, it is our aim to make the head to be at the same level of the rest of the body. So once the body is positioned, we usually choose the common carotid artery. Why we are choosing this artery? Yesterday it was clearly discussed. It is least prone for atherosclerosis, and it is very big vessel, which is very superficial and easy to work with. If we have any neck surgeries, we are unable to access the common carotid. We are forced to take up the femoral, but then we should be mindful that femoral will have a lot of disadvantages, and it has a very important disadvantage in that all the blood clots will be displaced towards the head end, and sometimes they go and block the head vessels, and the perfusion to head may not be thorough or complete. So during that time, we have to notice that, and we have to do what is called as restricted cervical injection, that once again Dr. Sarina has talked about yesterday. Once the vessel is isolated, it is always better to use the scalpel rather than the scissors to make an incision for inserting the cannula. While we are doing this dissections, it is always advised to do what is called as concurrent disinfection of instruments. Say, for example, we are using the scalpel to cut the skin, then we are once again placing it down. Once again, when we're trying to access the scissors, if we are accidentally getting into contact with the scalpel, and we'll have a nick injury, and it might be putting us at risk. Therefore, it is always required to have concurrent infection. So we take a tray, we put some phenol or formalin or alcohol, we put anything, and submerge all the instruments in that liquid, so that when we put them back into that liquid, they are immediately sanitized, and there is the reduced risk of getting infection. So during arterial injection, many things can go wrong. To start with, the body might have some abdominal tumor, which is pressing on the abdominal aorta, so that when we are giving the fluid through the femoral, so the fluid will not pass beyond the level of tumor. Therefore, the fluid will be leaking out of the abdominal aorta. So that is one thing. Same thing happens for ascites also. Therefore, it is always better to drain off the ascites. And in case of a huge tumor, it's better to avoid such bodies. Once we notice that the fluid distribution is not happening properly, it is better always to avoid such bodies to be allotted for surgical skill training. Next one is the intravascular resistance that can be caused because of some blood clots. These blood clots can be present because of certain vascular conditions called sepsis that happens before the death of the patient. So during such situations, the fluid distribution does not happen properly. Therefore, we can try to manipulate the tissue, flex and extend the joints. We can massage the tissue and try to see if that is yielding good results. And if it is not yielding good results, we can choose to have what is called as sectional embalming or restricted cervical injection to compensate for the areas where the perfusion has not happened properly. We should also be mindful that the fluid always takes the path of least resistance. That means the fluid usually goes to the vessels which are more larger. So if we see in the body, the skin vessels are more larger. Therefore, the outer parts of the body gets more fluid before the fluid even goes to the inner parts of the body. Therefore, this terminology called as shell embalming. Once again, you have listened to, you might have come across this shell embalming yesterday. So when we think that, okay, the surface skin is become hard, so we can stop. So that will be a pitfall. So we should wait for the deeper tissues also to get some fluid. Another the pathway of least resistance is the area around the injection site. So if we are choosing the femoral artery, the inguinal region will be embalmed first before even the fluid goes to the rest of the body. So these are the 2 points what we have to keep in mind before we conclude that the embalming arterial injection has been completed. So how do you monitor the fluid distribution? These are very important signs. So we have to look for a change of a color, and usually we use for anatomical embalming, we use this eosin dye. We use any kind of embalming, we can use this eosin dye so that it appears in the skin and we can observe for the change of color. Next is we should observe for the firming of tissue, that is hardening of tissues. So this is actually not a single step. This step happens across the embalming. That is, we have to observe it before embalming, we have to observe it during embalming, we should observe it after embalming also. Why? We think that the body has become hard when we observe it during embalming, but that might have been hard even before we started embalming. Say, for example, the body is severely cold and not adequately thawed, or if the body is having rigor mortis. Therefore, we should always compare the tissue's hardness from before the embalming to during embalming to the after embalming to say that yes, the fluid has percolated to all the tissues and the tissues are saturated with this fluid and are hard. Next one is there will be a slight decrease in the degree of skin elasticity. We can check this by pinching the dorsum of hand and checking the elasticity, decrease in the elasticity. And if we are using too much of formalin, that is the fluids which contain more of formalin, there will be a gradual dryness of the skin also. There are some more signs to observe for the completion or monitoring the embalming. That is the arterial injection, that is the filling and rounding up of tips of fingers and toes and lips, and there will also be distension of superficial blood vessels. If we are doing the drainage, concurrent venous drainage, we have to select the adjacent artery which is accompanying the vein, and once the vein is let out, there will be blood appearing in the drainage initially, followed by the fluid, that is the embalming fluid itself will appear in the drainage fluid. So this gives a clue that the arterial injection is going on fine. Now, during embalming, we might encounter this condition. This is called purge. This is otherwise called as oronasal purge. This is not a sign of completion of embalming. This is not a sign of even progression of embalming also. I'll tell you why this happens. So when we start injecting this fluid, the abdominal cavity fills up very fast because the abdominal aorta fills up the first. Either we go through carotid or femoral, the aorta fills first. When this happens, some amount of fluid is going to the intestines. So intestines are enlarging. They push the pelvic diaphragm and the thoracoabdominal diaphragm. Lungs are squeezed. Therefore, the contents of the lung and the contents of the stomach, they come out as nasogastric or oronasal purge. This only goes to show that the abdominal pressure, intra-abdominal pressure is increasing. Therefore, the lungs are getting squeezed. Therefore, the stomach is getting squeezed. But it does not in any manner indicate the progression or the completion of arterial injection. Next pitfall for observation is the firming of tissues. We have discussed this in the previous slide. We should be mindful that the hardened tissues might be because of rigor mortis or because of inadequate thawing. Let us see some mistakes that should be avoided, especially for soft embalming. Using the standard composition for all the cadavers. Say, for example, we have a workshop. We have 4 bodies planned for the workshop. One body is obese, one body is thin, one body is severely dehydrated, and one body has this sepsis. For all the bodies, we cannot give same soft embalming composition. We have to tighter based on the cause of death, based on the condition of the body. So therefore, I stress that each cadaver is unique. We have to treat it just like a patient. Yesterday, Dr. Saranya was also mentioning we cannot have one common composition, take a printout, put it on the wall, and everybody will follow that. That's a very wrong approach to take. It is said that it is always better to over embalm the body rather than under embalm the body, because under embalming will result in decomposition. And when we are observing for the completion or progression of the embalming or the arterial injection, the tissue forming or the change of color or the filling up of vessels, we should not go by any single sign. We should always take the decision of completion or the progression based on a combination of signs rather than a single sign. In this context, we should be mindful that the superficial aspects of the body will receive the fluid, therefore will become harder first when compared to the deep parts. So if we make a mistake of concluding the embalming, once the superficial tissues are hardened, then we end up in what is called a shell embalming, where outer parts is hard and inner parts are soft and therefore decompose. Okay, this point we have discussed. The fluid always takes the pathway of least resistance. Therefore, it should not be taken as a single sign. So we should always use a combination of signs. What are the best work practices? Always, even before we start off arterial injection, we massage and manipulate the body from the beginning to relieve the rigor mortis, to accelerate the arterial perfusion, and to accelerate or to propel the arteries, because sometimes there might be some clots. When we are massaging the tissue, the fluid will go beyond the clot. Okay, so that it is very important for the massaging to happen, and always prefer this proximal to distal aspect direction. We should also do this massaging of fingernails and nail beds, especially when we are planning for any finger or hand procedures. And we should also extend and flex the joints for joint procedures and all the cadavers. Followed by arterial embalming, we take up the same solution, that is the arterial injection solution, and we can take it up in a big syringe and we can inject into the abdominal cavity so that the peritoneal cavity will also receive some fluid, and if at all there is any ascitic fluid inside that cannot be drained, that will also get disinfected. Followed by that, I usually give, this is my preference, I usually give the intracranial injection through superior orbital fissure. So I go through the inner canthus of eye with a large needle. I blindly look for the superior orbital fissure. I poke and probe it. Once I'm through to superior orbital fissure, then I'll be injecting some to preserve the brain properly. Followed by this cavity, we do this hypodermic injection to all the parts of the body where the body is in contact with the table and the wooden planks. And we also take care of the surfaces if the body has small ulcers. So after that, we suture the injection site, we wash the body, we tag the body for identification purpose and put it in a plastic body bag and put it in cadaver storage. Followed by this, we always record our procedure. We record the composition. We record how much quantity was given, how much quantity went into the drainage, and we also record the other patient details for the record purposes. There are certain factors which affect the tissue consistency, especially in soft embalming. So the cause of death, if it is any vascular causes, say for example, sepsis, not good for soft embalming, therefore better to avoid. And if there is any delayed embalming, yesterday we have seen the time taken for utilizing the unclaimed body. So they are not very good for soft embalming. And in case of inadequate thawing, see, in the southern part of India, it might thaw within some 2 to 3 hours. In the northern part, in the colder regions of India, it might take 4 to 5 hours also to thaw once the body is taken out from the cold storage. We have to do this and observe what is good for our lab and standardize that. And this thawing time will also vary based on the obesity. If the body is thin, it is usually thawed very quickly. And if the body is very obese, it takes some time. And during embalming, we are required to do this relieving of rigor mortis. See, it's actually a part science and a part art. Therefore, we cannot leave this soft embalming work for the technician to perform or any other PGs to perform. It's always better to have a direct supervision and observation so that we know what is going wrong and we can take some remedial measures. And we should always make sure that it is better to over embalm the body rather than having an inadequate perfusion of tissues, which might result in failure of embalming and decomposition. Sometimes people will do this wrong fluid composition and expect better results. So this actually ends up in a failure of embalming. Therefore, even before we commit for the cadaveric workshops, we should always test the body, embalm the body, 1 or 2 bodies, and see what is working out for us. We should standardize our technique. Then only once we become confident, then we can announce to the clinicians that we are ready with the bodies for soft embalming. What are the ideal scenarios to get best of the results? Minimal time interval between the death and the embalming. So when the patient is died and if it is a voluntary body donation, it's an ideal candidate for allotting for soft embalming. And we can advise the patient relatives to put the body in cold storage. And if the body is not put in cold storage, it's better to get the body as soon as possible to the institution. And we should also have optimal injection pressure and amount of solution to get the best results. Lastly, what are the qualities of an efficient embalmer? So a person who can assess the condition of the body, choose the correct type of embalming technique, calculate the required strength, and monitor continuously the progress of arterial embalming, and evaluate and do any remedial measures as and when required. So this was that video. We have seen this, and I just want to leave you with one bonus slide. So either in the soft embalming or in the anatomical embalming, we are required to use this formalin. So how much of the formalin is required for the body is a enigma for most of us. So it is said that 4 grams or 4 to 4.8 grams of formaldehyde is required for fixing 100 grams of protein. And it is also estimated that 1 kilogram of human tissue contains 164 grams of protein, that is the 16%. So therefore, based on this, we have to calculate the total amount of protein present in the body and total amount of formaldehyde required for that protein using this formula, and then calculate the formalin required for that formaldehyde. The example goes like this. So the body, 1 kilogram body, 1 kilogram of tissue has this much of protein. So therefore 70 kilogram body has this much amount of protein, and the formaldehyde required for 100 grams of protein is 4.8 grams, and this 70 kg body requires this much amount of formaldehyde, and for this much of formaldehyde we need this much of formalin, because we know that formalin has 37% by weight and 40% by volume of formaldehyde gas. So with this, I conclude the topic of soft embalming, and I thank the participants for their attention, and I also thank the organizers for giving this opportunity. And I would be happy to answer the questions in the chat box because we are already running short of time. Thank you.
Thank you so much, sir, for delivering an enlightening lecture on soft embalming. Your expertise and passion for the subject were truly evident, sir. Thank you, sir. Now the topic is open for discussion. Questions are not yet posted, sir. Chat box has no questions now. Thank you, sir. Kindly accept the memento and the certificate for this session, sir, as a token of gratitude.
Thank you.
Now, I request Dr. Saranya ma'am to introduce the next speaker for the session, Dr. Navita Agarwal ma'am.
Thank you, Dr. Ambika. Very good morning, all. Dr. Navita Agarwal Madam is currently working as additional professor at Department of Anatomy in AIMS, Batinda. It is an absolute privilege for me to introduce our esteemed speaker, Dr. Navita Agarwal, Madam. She holds she's a Famer Fellow, and Madam is also a member of NIMHANS and FAMC, and she's a true innovator. Madam has invented a patented embalming device, and she has also developed a novel bone cleaning technique. Her diverse research portfolio spans cerebral artery anatomy, body donation, anthropometry, and fetal ultrasound studies and forensic applications. Madam has contributed over 30 publications to reputed journals and books, and currently she leads multiple research projects. Her leadership extends into various roles. She's the coordinator of the body donation program. She is the co-coordinator of the Center of Medical Education Technologies, and she also serves as the chief hostel superintendent at AIMS Bathinda. She is the active member of numerous professional bodies, and she is a very frequent CME speaker, conference chairperson, and resource person. Madam is not only known for her academic brilliance, but as a personality, she is deeply humble, very soft spoken, and highly approachable, making her a deeply respected and truly inspiring figure for us. I now invite Dr. Navita Agarwal, Madam, to kindly deliver her talk on bone retrieval. And this is one topic that remains least practiced among our fraternity, but yet it is very vitally important for all of us. We look forward to gaining valuable insights from you, Madam. Thank you, Madam. Over to you. Ma'am, 1 minute, ma'am. 1 minute. You're not audible. We are just sorting it out.
Am I audible? Am I audible?
Yes, ma'am. You're audible, ma'am.
Okay, so I need to go back to my slides. Good morning, dear participants. I am happy to be with JIPMER, and thank you, JIPMER, for giving me this opportunity. Today, I'll be talking about retrieving osseous tissue from deceased donors. And this, as ma'am has already said, is a bit ignored part of our anatomist anatomist bodies. Since yesterday, we have been talking a lot about how to procure bodies, how to preserve them. But I think we should also be talking about how to dispose of the used bodies, which is one of the important issues which we people face at times. And I'm eager to know how people are doing it. So, talking about the topic for today, retrieving osseous tissue from deceased donors. First of all, I would like to discuss the objectives for today's session. Our objectives for today's session would be indications and contraindications for bone retrieval, different types of bone retrieval procedures and their applications, importance of, just hold on. Is my screen visible? But I think there's an issue. Just hold on, I'll just get back within a minute. Yeah. So, importance of proper documentation and labeling of bone specimens and risks and complications associated with the procedures. So, before going to what all about this bone retrieval, what actually is bone retrieval? It is the preparation technique that involves or obtaining clean skeletal bones from the deceased body. And why do we need to do it? Mainly, it is for us in medical colleges, it is for the students so that we may be able to give them for the study purpose. And why do we need to retrieve bones and give it to the students? Though there are artificial bones available, the artificial bones are not having the markings actually like the true obtained bones from the cadavers. The original skeletons are costly. We all know we, AIMS Bathinda, being a new institute, have procured one skeleton for a cost of 6 lakhs. And for a group of 100 students, if I procure 25 skeletons, that would not be too much. And the cost, we can calculate how much it is costly for an institute. And any bone, it does, though it stays for long, but it tends to break down at the edges and it's not perfect. So we need to have ample supply of bones and keep renewing our bones. So for that also we need to retrieve the bones, original bones. And retrieving at no cost and making availability at plenty for students is one of the motives for cleaning the bones. Other than anatomist, we need for study purpose, we also need the bones for our museum specimens. I have seen a lot of anatomy museum specimens and the bones are nicely articulated. The skeletals are fixed, bones are marked for their attachments, and all this makes us to need to have lot of bones available in our departments. Other than that, research can be carried out on bones for anthropometry, for the histology purposes, and many more things can be done. And apart from anatomy purposes, the forensic people would like to have bones cleaned for their forensic interpretations. And last but not the least, what I feel a bit as a coordinator for body donation program, anything we get for donation, especially the bodies, should be used to the last bit. If we tend to use only the soft tissue dissections, cadaveric workshops, how do we end up using everything that we get for donation in donated bodies? So I feel the cadaver which has been donated should be used the last bit to pay respect to the donated cadaver. Now, how do we go about this? There are various steps that are involved in the procedure. The steps, I have labeled them as 1, 2, 3, 4, 6 till 6. And the first step is soft tissue removal, which we all know is also known as maceration. Then the second step is degreasing of bones. Then we go back for bleaching of the bones, labeling, bone articulation, and storage of bones. So I'll be just talking in brief how we go about all these processes so that we have bones ready at the end for our usage. Now, maceration, we've already said, it is the process of breaking down the soft tissue, that is the flesh, ligaments, or tendons attached to the bones. And usually the bones are submerged in water and the bacteria are allowed to do the work. This is the oldest and the commonest method of maceration, but this requires careful monitoring to prevent unpleasant odors and damage from over decompositions. Then another process that I've talked about is degreasing. This is the process to remove grease and oils. There are various steps to do it that I'll be talking in detail as we go by the presentation. So now maceration, as just now said, it is a method to remove the soft tissue from the bones, and there are various methods to remove the soft tissue from the bones. The commonly one enumerated are the cold water one, hot water, bug box method, enzyme maceration method, the burial method, and chemical treated method for maceration. I'll be talking about all of these one by one. First of all, the cold water maceration process is a very simple process. For this, the bones, whatever we have finished working upon or we feel the soft tissue is no more usable, we take the bony parts and we soak them in a container having cold or the regular tap water. It is not the cold water, it is the actual usual tap water in the department what we have. After soaking all the bones are the water is changed very frequently because the water becomes putrid, and we take care that there are no growths or dirty water is not there. So the precaution that we take here is keep changing the cold water after 1 or 2 days. And then we feel the bones have been macerated, the tissue is soft and ready to remove. We drain the water, we take out the bones, clean them, and if there is some debriefing required or brushing out required, we clean the soft tissue from the bones. And the advantage of this cold water maceration is that it can be easily done and there is not much damage to the bony specimens that we get. But the disadvantages of this process is it is a very smelly process and it is a time consuming, because maceration in regular water takes a lot of time for the soft tissue to get macerated, and also the entire part of the soft tissue is not clean from the bone. So we need to again scratch or remove the soft tissue from the edges of the bones. So my experience for cold water maceration is I have not used them for the bigger skeletons, but we used to get the fetal skeletons and fetal tissue for our department, and most of the fetuses which we could not use it for other purposes, we used to macerate the tissues of the fetus in the cold water. And the process was we kept the tissue fetus in a very small jar with water. We used to keep changing the water for this jar, and over a month or 2 months the tissue is macerated, and since the fetal bones are very small, it was easy to clean and handle them. So we have procured lot of bones for fetuses by using the cold water maceration process. Then another method that we have come across is the hot water maceration process, which involves soaking the bones in hot water. Actually, it is slightly boiling or simmering water that we use. Large bones are gently boiled. Smaller ones are delicate, so they have to be handled more carefully in this boiling water. And the water temperature also should not be too much hot or boiling for smaller bones, as they tend to break down. And after soaking thoroughly, boiling them for a longer period of time, the bones are taken out, dried, and then if there are soft tissue edges on the edges of the bone, they are cleaned out. And usually the precaution that you can see also in the picture, large vessels are used. We need a large big space. It should be like foolproof, so that we can burn fire there, and a person need to be standing around that place. And working with hot water with large vessels also risky, and these bones cannot be turned or handled, so we need to tie these bones with a string which can be handled outside the whatever pan or whatever vessel we are using for boiling. The process is faster as compared to the cold water process, but it has a potential for damaging the bones. So I find it difficult, and I have not practiced this process much because it requires a larger space to do this process. Then what we have come across in text is the bug box method and the enzyme maceration method. Bug box method is where the adult and the larvae dermatids are small insects, which picture I've just put it on the side just for you people to know how they look like. And the bones which need to be cleared with the small amount of soft tissue stuck on this are kept in a box which contains these larvae, and the box has to be slightly aerated so that the larvae are able to survive and move in around easily. But so this is also not a very convenient method to arrange these larvae and get the bones clean. The only advantage of having this bug box method is that the bones are not damaged by this process. In every method, wherever there is tissue macerating, the smell is there. Again, it is a smelly and a time consuming process, and we should be very clear that the bugs are just in the box and they are being aerated and they're not moving out of the box and around in the place. So again, I find this method a bit difficult to handle for our anatomy departments. Then another process that we come across is the enzyme maceration method. It is again that the bones are dipped with various enzymes like proteases and lipases, and for several hours to days, and then the flesh, because of action of trypsin in these enzymes, the fleshy part attached to the bones is softened and digested, and then the bones are cleaned with hard brush and then dried up for usage, right? So this is the enzyme maceration method. Then another method that I have just enumerated is the burial method. This is a very common method, and all of the anatomy departments are having burial grounds attached to them for disposal of the bodies. Now, what is done to the body after disposal in the burial ground is what we are talking about, the burial method. This I'll be talking about in detail once, and so I'll leave this here. Then another one is the chemical method. Chemical method is usually a lot of chemicals have been put down, like sodium hypochlorite, borax solution, laundry detergents, sodium carbonate, and many more are being used along with the water, either cold or hot, to soften the tissue and therefore macerating the tissues attached to the bones. Along with all these methods, is another thing that we need to use or be careful is manual cleaning. Slight amount of manual cleaning is needed in all the processes, because any bone being retrieved is not completely clean for direct usage. So manual is scrubbing the bones with a brush or a toothbrush to remove the dirt, debris, and tissues. So type of brush used will depend upon how much tissue is attached. If it is a lot of tissue, we need to soften it. We need a harder brush. But for many methods, I'll be just talking about just dirt and very little amount of tissue, which can be easily done away with the regular toothbrush. For removal of stubborn bits of tissue, cleaning bones, then bones need to be macerated again or degreased. If there is a lot of tissue, we need to go back for maceration again. And there is usually caution has to be taken for handling small bones, because manual cleaning and handling small bones will be difficult, and delicate bones of fetuses will also be difficult to handle by manual cleaning. So now, after having been talked about the maceration process, of which I'll be talking about in detail again, I'll be talking about what is degreasing of the bones. As already said, the bones, we all know bones has a bone marrow, and the bone marrow contains fat, and especially for the lower bones. So this fat has to be removed, because if it is not removed, the bones, after once have been made ready, would smell because of this fat and grease around it. So they need to be degreased. Usually the degreasing agents used are ammonia, benzene, acetylene, or many other degreasing agents like the enzymes that we have talked about, or the detergents also play a role for degreasing. The bones are soaked with these solvents in hot or cold water, or whatever solvent is prepared with the detergents or chemicals. And usually if there are larger animal bones, which we are not doing for, obviously, for anatomy departments, and if somebody is doing a comparative anatomy, if they want to clean the larger bones, then small amount of holes are need to be drilled into the edges of the bone, so that the whatever detergent or solution we are using, it enters the bone and the fat in the bone marrow is removed. And some precautions obviously have to be taken for using the chemicals that are being used. This is degreasing of the bones. And then next step, what we, after degreasing and having the bones cleaned off the chemicals which we have used, the usual step that we use is bleaching the bones. This involves the application of bleaching agents. This is just to clear the color, so that the appearance of the bones is increased, or you can say, if the bones are yellowish, they look better white. And though this is not a very compulsory step, but it can remove this process of bleaching. It can also remove even small bits of tissue if they are on the bones, as well as it also helps in removing the odor from the bones, so the bones do not smell once they have been prepared. And another additional process which I prefer doing with the bleaching is varnishing and painting of the bones. This also I'll be talking about how it is done, and this is for giving strength and protection of the bones. Then next to bleaching, when the bones are dried and ready and we think they are clean enough to be handled, we go for labeling of the bones. The labeling is usually done by markings or putting signs and tags or numbers, depending upon how you want to catalog your bones. Usually these days we have permanent markers, and they're very easy to put on a small part of the bone where we see the markings are not obscured. And this is what we have done at our institute also. And the bones can be properly, with the labeling, the bones are identified, easy to handle, count, and the bones are not mixed. Also, it is important, if you want to go for research purpose, we would like to segregate bones of one cadaver from another, so they can be marked or labeled according to that also. For separation of bones for a single cadaver, the precautions have to be taken from the initial processes of preparing the bone and separating the bone. So after labeling, we would like to go for articulations of the bone. Articulation is assembling the bones back together as they were in the living. And these articulated bones are part of our D halls, are part of our museums, and it can also be displayed. The articulation can be done with certain wires and screws, which is an older method. These days, if the bones are not very heavy, they can be used with powerful super glues also, which we have seen. The powerful super glues are also being used to articulate the bones. And then last part is the bone storage. This is also an important part which we usually overlook. After preparation, the bones are stored in bags, boxes, or mounted in preplex museums, the transparent ones, which will be helpful in exhibiting the bones for museums or forensic anthropology. And my experience of storing the bones is we have to keep them in open boxes and not the closed boxes with the lids, and in a room where there's proper circulation of air. If the bones are ignored and put in a room which is not having circulation of air, the bones tend to start smelling, and it is difficult to stand around that place. So they should be kept in open wherever the circulation is possible. So now, after discussing all this, we come to a conclusion that the success of any bone cleaning technique is determined by the time taken, the resources required, the results obtained, and the relative intent purpose for which the cleaning is required. So mostly for us as anatomists, we require these bones for study purposes, for handling it. Our students are going to handle it, or for museum and research purposes. So my personal experience of handling bones is I have worked with the burial method, so I'll be talking more on that. But in the discussion, we can take up other methods if we want to discuss. So bones, what I have worked up with, I told you we tried doing it with the cold maceration process, but it was time consuming and it was a very smelly, difficult to handle process for bigger bones. Then we continued that process for fetuses, which we used to get, and small bones were retrieved with the cold maceration. But for the larger specimens, like the remnants from the dissection hall after dissection for 1 year, or after the soft tissue embalming and surgical workshops, if the cadavers were there and they are of no use now, they will not be used for soft tissue usage. So then we used to bury these cadavers, and while burying, taken was care so that the place is labeled, which and the tails of the cadaver which is buried is being taken off care of. So after burial, in the burial ground, with proper precautions of how the burial ground should be made, the bones were extracted after 1 year of burial. These bones were then washed thoroughly with the regular tap water to remove all the dirt and the mud around, and the leftover soft tissue which was there was minimal and if it was there on the larger bones, only at the edges, little amount of soft tissue which we had found was there. We try to dry these bones to the maximum so that the soft tissue which is attached to the bones also becomes dried out. So after this is like the pictures that we have taken after initial cleaning and removing the mud and dust from the retrieved bones from the burial ground. Then what we did was the hydrogen peroxide solution, which is available in the market with a concentration of 50% weight by weight. We used it for cleaning. The cleaning solution we prepared, I tried it for various methods, various concentrations, and the best that I could take out was ratio of 1:2 hydrogen peroxide with water. And this is the normal tap water which is available. So we prepared the solution with 1:2 ratio of hydrogen peroxide, 50% weight by weight to water, and we prepared a big bucket and had dipped the bones, and within half hour of dipping the bones, we saw the bubbles were appearing in this hydrogen peroxide solution. The precautions that we had taken while doing this was the bones were kept in the dark so that the hydrogen peroxide is not inactivated very fast because of light. And after about 18 hours of dipping, like if I'm leaving my department at around 5, I would start the process at 2, and by 5 I would be done dipping with the bones, and then I leave it overnight, and by next day morning we come out and we take out the bones from the solution. To my observation, most of the bones were clean and had, even if there was a small little soft tissue stuck off, it was, the moment you touch it, it would scrape off from the bone. This is one thing that I noticed after using the hydrogen peroxide. Apart from that, the bones were cleaner and more whiter in color. So we took out the bones and we allowed the bones to run under tap water so that the entire hydrogen peroxide in the bones were washed off. And then we tried to dip it in the simple tap water for 1 or 2 hours so that if there's a penetration of hydrogen peroxide within the bones, that also is cleaned off. 1 or 2 changes of fresh water were given, and then the bones were taken out and dried on a cotton cloth, not in the sun, just in the room under the fan. So this is what was taken out. So with the simple method of dipping the bone in hydrogen peroxide for 18 hours, this is the result what we got. And then even the skull bones were cleaned with the similar method. We can see even every part of the skull bone is clean. The smaller and the bigger bones all were clean. So the dried bones were then painted. So that is what I was talking about, varnishing and painting of the bones to keep store the bones and protect them, and to have a longer life for these prepared specimens. A wood polish solution was prepared with the turpentine oil, whichever is available in the market for wood polish. We diluted that solution and we tried dipping the bones in the solution, quickly taking them out. And these dried this process was done after the bones were completely dried for 2 to 3 days. When we were sure the bones are completely dry, then the wood varnishing would be done. So after dipping them, they were again dried under fan for 2 to 3 days on plastic sheets and under the shade. So after preparation, this is, you can see a bit of shiny thing on the bones, and they're totally clean. Even the skulls are clean. So this is the final appearance of the bones after polishing and drying and ready to be used by the students. And for comparison, we have put the initial bones that we had taken, which were still had to undergo the process, and some of the ones which were clean. So this picture, I think it makes it clear. The larger bones, the longer bones, skulls, thicker bones, and even thinner bones like scapula. Here we see, even though the cortical tissue is very less on scapula, there is no damage to the cortical tissue. Usually we find the scapula is broken, the small pieces of spongy bone are coming out of scapula in the departments. But in this way, the entire scapula was clean, larger, longer bones, the skull bones and everything what I found out was up to the mark, ready to be used. So with this, we came to a conclusion that though boiling, cold maceration, all these are processes, these are the time-tested methods used since long in the departments, but they require big equipment and special place for this process. The lot of time is required. There is smell emitting out while this process is being taken, and it cannot be carried out in a regular D hall or embalming area or storage area. We need a special area for doing this hot water or cold water maceration process. During the process of boiling, a person needs to be around to keep the check on endpoint. If it boils too much, the bones tend to break and become fragile. So by the practice of method of burial and then cleaning the bones with H2O2, as mentioned, it was easy. We could do it off the time areas, like even the tank, this bucket was kept in the D hall. If we did not have space, after the students are gone, we do it overnight and then we keep it. Another positive thing to using H2O2 method after burial of the bones was that once the H2O2 solution is used, I understand it becomes weaker, but it can be used for another wash or a third wash also, so that we use the chemical to the last. Or every time, once the first wash of bones have been taken, we add a little amount of hydrogen peroxide again and use it for a second wash. And even if we don't add, if we use it for a second wash, the next time we dip the bones, it would take less time to clean. So the chemicals required in this procedure are easily available. Not much heavy equipment have been used for this H2O2 process, and manpower that has been used is not much. Only a single person who could dig the bones from the burial ground, bring it to the D hall, wash it off and put it in the solution can be doing this process. Only one person is handling it, and without much of risk with the chemicals. It is only H2O2 for which precautions of handling is to be taken. Then the time needed here is, though in the washing process time is less, I agree the time for burial will be long. So this process will be useful when we want to prepare our bone bank for our departments, where we want to collect bones over a period of time so that we can prepare bags of bones. And for this collection of bones, I had prepared departmental bags, each with the set of bones being given to the students. At the beginning of the year, when the batch joined, we used to give them the complete set of bones from the department. The student kept it with themselves, and at the end of the year, they returned. With this, we have ample collection of bones, and a big bone bank has been prepared. So with this, I could conclude, apart from the burial time, which is approximately 10 months to 1 year, that also I'm saying, if these are formalinized bodies, it takes 1 year. If they are soft, this unembalmed or bilkul fresh cadavers which were used for surgical training, they took about 9 to 10 months for after burial, for before digging up. And the number of bones which can be cleaned at one point of time was very large, and within a period of 7 days, one set of bones can be completely gone through and be ready. And for us, we had tried preparing 10 cadaveric bones at one point of time within 1 week, and we were successful in that area. And since no special place, equipment, or procedure things were done, we preferred using this process. So this is the burial method, and the bleaching along with removal of soft tissue has been done and taken out, and this I feel is an advantageous method and can be done easily with all the departments who have burial ground for disposing. And with this, we were able to use every bit of the donated bodies. So these are my references, and I would be happy to take questions if there are any doubts over this. And thank you, delegates, for being there and listen. I'm ready to take questions if there are any.
Hello,
Thank you
ma'am.
so much, ma'am.
Rajshekar here. I have a question.
Yes, sir.
Let me first congratulate you for doing an excellent job with the bones. We have worked with the bones. It's not an easy job, and you've got very good results. And I must appreciate your strategy also to prepare this bone banks and issuing it to the students for their individual use. That's a very good
Yes, sir.
strategy. My question is this, ma'am. So when
Yes.
we try to bury these bodies, when we take out the bodies, the medial wall of the orbit is most often observed to be damaged because of the sensitive, very thin layer of this ethmoid bone. So, how much depth do you usually choose to bury the body if at all we are planning for exhuming the bones?
So actually, I've been working on this, and since I'm just making a new burial ground for our new institute also, what I've experienced is when I started this work, we had untrained workers there. They used to dig the bodies only 2 feet deep in the regular hard soil, wherever initially that was a area where grass was growing, and that was then allocated to Department of Anatomy. They just dig the bone about 2.5 feet deep, and then dig the bones. But this problem of what you have enumerated here, that the medial wall of the orbit was damaged, I have never encountered. I can go back to the pictures and see that enough number of skulls have been taken out, and none of the skulls I have observed that the medial wall is damaged. And regarding the depth of digging is only 2 feet to 4 feet maximum. If the soil we feel is very tough and tight, which I feel is the regular soil in for grass here, the regular ground soil, it is 2.5 feet, not deeper than that. Means it in just with the 2 or 3 digs, we reach the cadaver. And if it is what I have now planned doing is, I don't know how do you speak it at your place. It is a local language we say. It is the Rajasthani soil which does not soak much of water, and it is aerated. So this is what we prefer. What we are preparing now is a 4 feet deep area, which we will fill it with the mixture of the ground soil and the this sand, I can say, which remains porous. It does not hold water, so it allows aeration and the bugs to go in. And the maximum is 2.5 to 4 feet of depth, not deeper than that we have ever done it.
Okay, ma'am. So maybe we have to revise our strategy of digging a more shallower depth and
Yeah,
having a softer sand, which is more
yeah,
porous for the water to
porous.
percolate.
Yes,
One more query, ma'am. When we were
yes, sir.
trying to clean the bones,
Mhm.
especially the skull bones, when we are trying to use the toothbrush,
Yes, sir.
we had certain difficulties when we are inserting the toothbrush into the smaller crevices. Do you use any other tool apart from the toothbrush?
Sir, actually, in my process, if you would have taken note of this, most of the soft tissue was removed. I have not used toothbrush for cleaning delicate bones like skulls. The skulls that I've shown, we have not handled them with any of the brushes. This is when we dig out the thing, which is what I feel is, even my counterpart anatomists we are working with, people are not giving importance to burial. So what I felt after working for 14 years with burial process is, burial is the most important process. It removes the entire soft tissue from the depth of the skull also. I haven't found much soft tissue within the skull also after 1 year complete burial. So, like I just for you personally, sir, we are a new AIMS, and burial ground was not given to us as part of anatomy here. Once we joined, we have been behind our administration, and a big land has been allotted from ministry in our institute for the burial ground, and we have designed it completely, and we are in the process of making it. So, I feel the complete time for burial removes the software. We do not need to. I haven't personally used anything to clean the skulls as I just said. Even if there's a small bit tissue, we take out the bones when we put away the dust and all, we let the soft tissue dry. And this brittle dried soft tissue within hydrogen peroxide is usually clean. So we did not have to clean. And even the skulls which I have cleaned with hydrogen peroxide, after that, to disarticulate the skulls, I use that the black chana method also, and one or two methods. After disarticulation, I've displayed in one of my slides, the bones were completely clean from within also. So I have not come across this problem of scratching the skull softer bones from inside. And sorry, I was not able to answer your question about the instrument which is to be used.
Okay. Thank you, ma'am. Maybe we have to revise the strategy of the depth and the soil. Okay, probably we'll try it out.
What I felt was a lot of bugs and aeration is important for the tissue to be eaten faster.
Okay, very good, ma'am. Thank you for sharing.
Thank you, sir. So if there are no more questions, I can wind up the session. Dr. Saranya?
Thank you, ma'am. Thank you so much, ma'am, for shedding light on the details of retrieving the osseous tissue from the deceased. Thank you, ma'am, for sharing your knowledge and expertise with us.
Thank you, Dr. Saranya and team, for giving me this opportunity.
Thank you.
There are questions in the chat box. Would you like me to answer them?
Yes, ma'am. We can go for open discussion of the topic, ma'am.
Okay. One question that I could read in the chat box was, did you use salt for burial? I have not used any salt. It is just after usage of the body, whether fresh cadaver or a formalin fixed cadaver. We have just buried it, just not very deep, just as I've just now discussed, in the burial ground. Nothing has been put for the cadavers. One thing that what I have tried is I have put polythene, the plastic net around each cadaver so that I can retrieve one cadaver bones in one plastic mesh. Along with, like, we put the cadaver in lot of in the, we put the net on the dug thing, and then we put a mesh over there, again put a soil, put the cadaver on it, nicely cover the cadaver with the soil and close the back so that it is nicely covered. And with this we could even retrieve the single cadaver bones together for labeling and articulating them and separating them as male female bones for research purpose. There's a question from Samita Ji Raj. Some of the bones were kept for a long time in a department, mostly long bones have their ends getting broken. How to avoid that? Madam, I put an emphasis on this point that bone ends which are being broken are because the older bones which are in the departments are not varnished. To fix that edge, we have covered the bones with the varnish, wood polish, and the varnish mixture. And if we feel still they are breaking, we keep repeating that process yearly or after 2 years. Whenever we feel some of the bones are breaking, but if you try doing this process, the bones are not breaking. And like for last 5 years, I've been using those bones regularly with the students, and we don't find the edges breaking because we've already fixed the edges with the varnish and the wood polish paint. So the bones are better, safer than that. So after cleaning, the bones are very dry. So just to give a complete and packaged edge, we have varnished the bones and packaged them nicely. For Dr. Sonia, for how much time do we keep the bones in cold and hot water for maceration process? Ma'am, for cold, it takes a lot of time. It is more than a month for a fetus to macerate. So as I said, I have not used it for bigger bones. If it is a lot of soft tissue stuck to the bones, we haven't removed it with a scalpel, it might take even more. For one fetus to macerate, it takes more than a month to give me complete bones from 7 to 8 months fetus. And for hot water, what I've read in the theory with people practicing it, they say it is 2 to 4 hours. And me, I have not practiced personally on hot water. There's a question from Nirmala Sir. Ma'am, let me know the quantity of H2O2 with water, how much we have to give. Ma'am, this is, I have a paper published as with the name of an alternative method for bone cleaning. It gives the entire details of how it has to be done. And to quantify it, the hydrogen peroxide that I got from the market was 50% weight by weight. So we use this 50% weight by weight hydrogen peroxide solution in the ratio of 1:2 with water. 1 part of hydrogen peroxide and 2 parts of water was used for a good result in 18 hours. We practiced doing it, titrating it with various levels. The best was 1:2 with 50% weight by weight hydrogen peroxide. And hydrogen, the subsequent washes are with clean water. We do not need to do it with hydrogen peroxide. One dipping for hydrogen peroxide for 18 hours is enough, and rest is just to clean off hydrogen peroxide. We need to give 2 to 3 dips of running water wash. So since I don't see many more questions, amount of time taken for tissue to macerate can be depending upon your temperature conditions, the burial depth, how much soft tissue was stuck to the bones when they were buried. So since it is depending upon too many factors, how much exact time can be taken will depend upon where we are working. And with, like, if I bury a complete cadaver without removing the soft tissue, it might take longer. So, but if a lot of soft tissue has been removed and only it is stuck on the joints and edges of the bone, it might do it earlier. So for me, it comes about to 10 months to 1 year, depending on the conditions where they are buried. Cold water temperature is the usual room temperature water. For hot water, it is once the water is boiling, we dip the bones and allow it simmer. So the temperature as such is not noted as such how many centigrades, but the only thing that we do is once the water is boiling, we dip the bones and then allow it simmer. The bones are not boiling in the water. They have to be simmering in the water. So this is what we take care of. There's a question from Dr. Shavi Garg. If the bones already get fragmented with the solution, ma'am, this is what we are putting on. If the bones are fragmented, they're of no use to us. So we take care that the whatever solutions are being used or whatever amount of boiling is being done is not more than required. We have to standardize the method so that we do not fragment the bones. If the bones are fragmenting in solution, your solutions are very strong. So we need to titrate them back so that we get complete bones. So since I'm seeing no more questions, so can we wind up the session, Team Jipma?
Yes, ma'am. Sure, ma'am. Thank you, ma'am.
Thank you. Thank you.
Sharing.
Ma'am should stop sharing screen.
Kindly accept the memento and the certificate for the session, ma'am, as a token of gratitude. Next, we would like to share a thought-provoking video created by our first-year MBBS students on the noble topic, voluntary body donation.
வணக்கம் டாக்டர் சார்.
வா லோகேஷ், எப்படி இருக்க? பார்த்து ரொம்ப நாள் ஆச்சு.
நான் நல்லா இருக்கேன்ப்பா. நீ எப்படி இருக்க?
நான் நல்லா தான் இருக்கேன். என்ன திடீர்னு இந்த பக்கம்?
ஏதோ ஊரில் ஃப்ரீயாக மெடிக்கல் கேம்ப் பண்ணுறேன்னு கேள்விப்பட்டேன். அதே என் நண்பனை பார்த்துட்டு அப்படியே ஓசியில் செக்அப் பண்ணிட்டு போகலான்னு வந்தேன்.
ஓ சரி, எப்பவுமே வரமாட்டேன், அதான் திடீர்னு வந்திருக்கு. சரி ஓகே. உன் பையனா?
என் பையன் தான்.
உன் பேர்ரா?
நான் சந்தோஷ் சார்.
ஓ, என்ன பண்ணுற?
நான் நீட் முடிச்சுட்டு இப்போ தான் சார் ரிசல்ட்டுக்கு
ஓ சரி சூப்பர். சரி, உனக்கு செக்அப் பண்ணிடுறேன். கண்ணாடி மட்டும் கொஞ்சம் கட்டு. ரகுனா ஞாபகம் இருக்கா உனக்கு? எப்படி இருக்காங்க அவங்க?
உனக்கு விஷயம் தெரியாதாப்பா, அவர் கொஞ்ச நாள் முன்னாடி தான் இறந்துட்டாரு.
என்னாச்சு?
ஹார்ட் அட்டாக்கா?
ஹார்ட் அட்டாக்கா? அப்புறம்?
அதான் அவர் சொந்தக்காரங்கெல்லாம் வர வரைக்கும் மார்ச்சரியில் வச்சுருக்காங்க.
ஓ, இப்போதான் இருந்தாரா?
ஆமாம், இன்னைக்கு சாயந்தரம் தான் சடங்கு இருக்குது.
ஓ, மார்ச்சரியில் வச்சுருக்காங்களா? சரி சரி. சடங்கு பண்ணுறீங்களா? உனக்கு உடல் தானம் பற்றி தெரியாதா?
உடல் தானமா? அப்படின்னா என்ன?
இப்போ உடல் தானம்னா, இப்போ ஃபஸ்ட் இயர் மெடிக்கல், இப்போ அவன் பையன் இருக்கான்ல, அவன் நீட்டில் நல்ல மார்க் எடுத்தால் ஃபஸ்ட் இயர் போவான். இப்போ அங்கே உடல் தானம் வச்சு தான், அதை வச்சு தான் படிப்பாங்க. அது மாதிரி நிறைய விஷயம் இருக்குது. அவனுக்கு தெரியலனா தெரிஞ்சுக்கோ.
நான் உடல் தானம்லாம் பண்ண மாட்டேன், சடங்குலாம் இருக்குல்ல.
ஓ, அது உன் இஷ்டம். நீ என்ன பண்ணுற? ஓ, நீ காலேஜ் ஜாயின் பண்ண போகிற சொன்னல, எந்த காலேஜ்?
நான் ஜிப்மர் காரைக்காலில் படிக்கலாம்னு ஆசைப்பட்றேன்.
ஓ சரி. எக்ஸசைஸ் மட்டும் பண்ண சொல்லு, மற்றபடி சுகர் மட்டும் குறைச்சிக்க சொல்லு, மற்றபடி எந்த பிரச்சனையும் இல்லை.
ஓகே சார்.
சரி, போயிட்டாங்க. தேங்க்யூ தேங்க்யூ. ஆல் தி பெஸ்ட்டா.
ஹலோ.
ஹலோ, எப்படிப்பா இருக்க?
அப்பா நல்லா இருக்கேன்ப்பா. அப்பா இன்னைக்கு ஒரு அதிர்ச்சியான செய்திப்பா.
என்னப்பா ஆச்சு?
அப்பா இன்னைக்கு கிளாஸ்ல முதல்ல சடலத்தை காண்பிச்சாங்கப்பா.
ஆ,
அதுல சடலமா படுத்து கிடந்தது ஆ, நம்ம டாக்டர் அங்கிள்ப்பா.
டாக்டர் அங்கிளா?
ஆமாப்பா,
அவர் தானே, நிச்சயமா தெரியுமா?
அவரே தான்ப்பா. நான் மூச்சு ஆயிட்டேன்ப்பா.
ஐயோ, அவருக்கு என்னாச்சு? ஏன் அவர் உடம்ப இப்படி தானம் பண்ணி பண்ணணும்?
என்னப்பா ஏன் இப்படி ஆச்சுன்னு கேக்குறீங்க? அவர் ஒரு டாக்டர்ப்பா.
ஆ,
அவரும் இந்த துறையில தான்ப்பா இருக்கிறாரு. அதனால அவரு இறுதி மூச்சு பிறகும் சமுதாயத்துக்கு உதவி செய்யணும்னு சொல்லி இந்த மாதிரி உடலை தானம் செஞ்சிருக்காருப்பா.
சமுதாயத்துக்கா? அது எப்படி?
அது இப்போ இந்த சடலத்தை வச்சு நாங்க மட்டும் படிக்க மாட்டோம்ப்பா.
ம்.
பெரிய பெரிய டாக்டர்லாம் சிகிச்சை செய்யறதுக்கு முன்னாடி இந்த
ஆ,
மாதிரி சடலத்துல ஒரு தடவை பயிற்சி எடுத்துக்குவாங்கப்பா. இப்போ
ஆ,
புது புது கருவிகள், மாதிரி எலும்பு பொருத்துறது, செயற்கை உறுப்புகள் இந்த மாதிரி
ஆ.
பொருத்துறதுக்கு முதல்ல சடலத்துல பயிற்சி எடுத்துக்கிட்டு அதுக்கப்புறமா தான்ப்பா இங்க செய்வாங்க சிகிச்சையில.
ஓ, இவ்வளவு விஷயம் இருக்கா உடல் தானத்துல?
ம்.
டாக்டர் சார் ரொம்ப பெரிய விஷயம் பண்ணிருக்காரு. அவர் ஆன்மா சாந்தி அடையட்டும். நாளைக்கு நானும் அம்மாவும் அவர் வீட்டுக்கு போய் அவங்க குடும்பத்தை பார்த்துட்டு வரலான்னு இருக்கோம்ப்பா.
ஓ, ஓகேப்பா.
சரிப்பா, வச்சிடுறேன்.
சரி.
ஏதாச்சும் குடிக்கிறீங்களா? டீ, காஃபி? இல்லை,
ரொம்ப நல்ல மனுஷன். ரொம்ப கஷ்டமா இருக்கு.
எங்க பையன் நேற்று தான் காலேஜ்ல இருந்து கால் பண்ணி சொன்னான், உங்க கணவர் அவரோட உடலை சடலமா காலேஜ்க்கு தானம் செஞ்சுட்டாரு. கேட்கவே ரொம்ப அதிர்ச்சியா இருந்துச்சு. கேட்கறேன்னு தப்பா நினைச்சுக்காதீங்க, ஆனா செய்ய வேண்டிய சடங்குலாம் செய்யாம ஒருத்தரோட ஆத்மா எப்படி சாந்தி அடையும்? அதை பத்தி யோசிக்காம என்னால இருக்கவே முடியல.
பரவாயில்ல. உங்களுக்கு மட்டும் இல்ல, எங்களோட இந்த முடிவை பத்தி நிறைய பேருக்கு நிறைய கேள்வி இருக்கு. அவருக்கு வழக்கமான சடங்குகள்லாம் எங்களால செய்ய முடியல, உண்மைதான். ஆனா அவரோட உடலை தானம் செஞ்சது மூலியமா இந்த மனித குலத்துக்கே நாங்க ஒரு பெரிய உதவி செஞ்சிருக்கோம். நம்மளோட உடம்புல இருந்து கத்துக்கிறதுனாலதான் நிறைய சிறந்த டாக்டர்ஸ் எல்லாம் உருவாக்குறாங்க. அதனால இன்னும் ஆயிரக்கணக்கான உயிர்களை காப்பாற்றவும் முடியுது. இதுக்கு இன்னொரு வழி கூட இருக்கு. நம்ம வழக்கம் போல எல்லா சடங்குகளையும் செஞ்சுட்டு இறந்த 6 மணி நேரத்துக்குள்ள உடம்பு கொடுத்தா கூட போதும். அதுவே உங்களுக்கு ரொம்ப உதவியா இருக்கும். என் கணவரோட ஆத்மா சாந்தி அடைறதுக்கு இதை விட ஒரு சிறந்த வழி இருக்கா?
உண்மைதான், மக்களோட உயிரை காப்பாற்றுறது இது ஒரு சிறந்த வழி. இருந்தாலும் ஒரு சடலமா இருக்கும்போது நம்மளுக்கு தகுந்த மரியாதையோட நடத்துவாங்களா? பல பேராக நம்ம உடல் சிதைக்கப்படுது இல்ல?
இல்ல, அப்படியெல்லாம் நடக்காது. ஆசிரியர்களும் மாணவர்களும் படிக்கும் போதே சடங்குக்கு தேவையான மரியாதையெல்லாம் செலுத்தி உறுதிமொழியெல்லாம் எடுத்துக்கிறாங்க. அது மட்டும் இல்ல, தேவையில்லாம சடங்குகள் எல்லாம் சேதப்படுத்தாம மனித உடம்பை பத்தி படிக்கிறதுக்கு, அதை கூறு போடுறதுக்கு ரொம்ப கடுமையான விதிமுறையெல்லாம் இருக்கு. மனித உயிர்களை காப்பாற்றுறதுல அக்கறை இருக்கிறவங்க கண்டிப்பா என் கணவரோட மரியாதையோட தான் அனுப்புவாங்க. நான் நம்புறேன். உங்ககிட்ட இன்னொரு விஷயம் கூட சொல்லணும். நான் கூட என் உடம்பை தானம் செய்வதற்காக பதிவு செஞ்சிருக்கேன்.
அதெல்லாம் சரி,
ஆனா நிறைய பேர் முன்னாடி நம்ம உடம்பு ட்ரெஸ் இல்லாம இருக்கிறது அது எப்படி நல்லா இருக்கும்?
ஆசிரியர்களும் மாணவர்களும் மனித சடலத்தை அவங்களோட மிகப்பெரிய மதிப்புமிக்க தொழிலா பாக்குறாங்க. இன்னும் ஏன் நமக்கே உடம்பு சரியில்லை, அதுக்கு அப்போ வந்து டாக்டர் கிட்ட போய் செக்அப்காக ஆபரேஷனுக்காக தான் ட்ரெஸ் இல்லாம காமிக்கிறேன்னு செய்யறோம். மண்ணுக்கு போற உடலை மனித உயிர்களை காப்பாத்துறதுக்காக கொடுக்குறோம். அது நல்ல விஷயம் தானே?
ஆமா, அதுவும் சரிதான். இது தெரியாம நான் உங்ககிட்ட நிறைய கேள்வி கேட்டு உங்களை ரொம்ப கஷ்டப்படுத்திட்டேன். என்ன மன்னிச்சுடுங்க.
பரவாயில்ல விடுங்க. இப்ப
ஆமா ஆமா, நம்ம கஷ்டப்படும் போது நம்ம காப்பாற்ற டாக்டருக்கு நம்ம உடலை கொடுத்து உதவுறதும் இந்த சமுதாயத்தை காப்பாற்றுறதும் நம்ம பொறுப்பு.
நம்ம நாடு முழுக்க நிறைய மருத்துவ மாணவர்கள் ஆர்வத்தோட இந்த மருத்துவ படிப்பை படிக்கிறாங்க. ஆனா அவங்களுக்கும் சொல்லிக் கொடுக்கறதுக்கு நம்ம கிட்ட போதுமான சடலங்கள் இல்லை. உங்களுக்கே தெரியும், நம்ம நாட்டுல ஜனத்தொகை ரொம்ப அதிகமாகிட்டே போகுது. அவங்களுக்குலாம் ட்ரீட்மெண்ட் கொடுக்கறதுக்கு நல்ல சிறந்த டாக்டர்ஸும் தேவைப்படுறாங்க. ஆனா அவங்களுக்கு சொல்லிக் கொடுக்கறதுக்கு போதுமான சடலங்கள் இல்லை. இதுக்கு ஒரே வழி என்னன்னா உடல்தானம் செய்யறதுதான். அது மட்டும் இல்ல, மருத்துவ படிப்புல மாணவர்களுக்கு சொல்லிக் கொடுக்கறதுக்கு மனித சடலங்களுக்கு ஈடா வேற எதுவுமே இது வரைக்கும் கண்டுபிடிக்கப்படல. இது நம்மளால செய்ய முடியாத ஒரு மிகப்பெரிய உதவி. இது மூலயமா நம்மளாலையும் நிறைய உயிர்களை காப்பாற்ற முடியும்.
உடல் தானம் செய்ய எப்படி பதிவு பண்ணு?
நீங்களும் இந்த மாதிரி உங்கள் உடம்பை தானம் செய்யணும் அப்படின்னு விரும்புனீங்கன்னா அதுக்கு நிறைய வழிமுறையெல்லாம் இருக்குது. அதுக்காக முதல்ல என்ன பண்ணணும்னா, ஜிப்மர் காரைக்கால்க்கோ இல்லை பக்கத்தில் இருக்க ஏதாச்சும் ஒரு மெடிக்கல் காலேஜுக்கோ போயிட்டு அங்கே இருக்கிற உடற்கூறியல் டிபார்ட்மெண்ட்டில் உங்கள் விருப்பத்தை சொல்லுங்கள். அவங்க உங்களுக்கு ஒரு விருப்ப படிவம் தருவாங்க. அதை நீங்கள் வாங்கிட்டு போய் அதில் உங்கள் டீட்டெயில்ஸ் எல்லாத்தையும் ஃபில் பண்ணணும். ஃபில் பண்ணிவிட்டு உங்கள் கையெழுத்து போடுங்க. உங்கள் சொந்தக்காரங்கக்கிட்டேயும் உங்கள் முடிவை சொல்லி அவங்களுக்கு புரிய வச்சு அவங்க சம்மதத்தையும் வாங்கி அவங்கக்கிட்டையும் கையெழுத்து வாங்குங்க. இந்த ஃபில் பண்ண ஃபார்மோட 2 பாஸ்போர்ட் சைஸ் ஃபோட்டோ, அதுக்கப்புறம் ஆதார் கார்டு, இது எல்லாத்தையும் ஒன்றா சேர்த்து அட்டாச் பண்ணி திரும்ப அந்த உடற்கூறியல் டிபார்ட்மெண்ட்கிட்டே போய் கொடுத்துடுங்க. அவங்க உங்கள் டீட்டெயில்ஸ் எல்லாத்தையும் செக் பண்ணிவிட்டு உங்களுக்கு வந்து ஒரு டோனர் கார்டு தருவாங்க. மரணம் ஏற்பட்ட உடனே உங்கள் சொந்தக்காரங்க எல்லோரும் வந்து உடற்கூறியல் டிபார்ட்மெண்ட்க்கு வந்து நீங்கள் இன்ஃபார்ம் பண்ணிட்டீங்கன்னா அது கூடவே வந்து கண்டிப்பாக உங்களோட மெடிக்கல் டெத் சர்டிஃபிகேட்டையும் கொடுக்கணும். அதுக்கப்புறமா அவங்க வந்து தேவையான எல்லா ஏற்பாடையும் பார்த்துப்பாங்க.
Thank you everyone. We thank the first year MBBS students of Jipma Karaikal for preparing a video. Now I welcome Dr. Vijay Kishan sir, Assistant Professor Anatomy Jipma Karaikal, to introduce the next speaker, Dr. Suganti ma'am.
Thank you, Dr. Ambika. I take this opportunity and I'm happy to introduce Professor Dr. Suganti ma'am. Ma'am is currently a senior professor, Department of Anatomy, Christian Medical College, Vellore, and with experience of over 25 years of teaching UG and PG students across medicine, nursing, and allied health sciences. And ma'am has authored over 80 peer-reviewed papers and contributed to Cunningham's Manual of Practical Anatomy. And ma'am's area of interest in research include cadaveric anatomy, histology, radiological correlations, plastination, education innovation, and interdisciplinary integration. And ma'am is former head of the Department of Anatomy, CMC Vellore, and ma'am is associate editor of National Journal of Clinical Anatomy and Register CMC Vellore. And ma'am was awarded Dr. P.C. Bansal Memorial Gold Medal for the Best Histology Paper 2016 at International Fellowships in Germany and Sweden. and ma'am is also a guest speaker and resource person at various national and international conferences, and also reviewer for multiple journals. I request, and ma'am will be talking on this topic, the art of plastination, transforming anatomy education and research. I request Dr. Suganti ma'am to take over. Thank you.
Good morning, everyone. I thank Jitma Karekal for giving me the chance to talk about the art of plastination, transforming anatomy education and research. The objectives for my talk are principles and methods of plastination, including different types of plastination techniques, equipment, materials, and safety protocols required for different types of plastination techniques, applications of plastination in medical education, research, and healthcare, and limitations of the method. First, we'll talk about the principles and methods of plastination. What is plastination? It is an innovation in the art of preserving bodies or body parts. The definition of plastination is it is the process of preservation of anatomical specimens by impregnation with curable polymers like silicone, epoxy, or polyester resins, which keep the anatomical specimens in a dry and odorless state. The specimens preserved in this manner are clean, non-toxic, and dry. They are called as plastinates or plastins. Plastination was first developed by Dr. Gunther von Hagens at the Department of Anatomy, Heidelberg University, Germany in 1979. The word plastination is derived from the Greek term plastin. It means to shape or to form. The term plastination was in fact coined by Gunther von Hagens. What are the advantages of plastination? Plastinates are clean, non-toxic, dry, odorless, durable, flexible, and robust. They are easy to store, so that eliminates the maintenance cost of the formalin tanks. And it is easy to handle, so that makes the students to handle the specimens more, and thus it becomes an excellent teaching tool. And they make good museum specimens also. What is the principle of plastination? So plastination is a method of preserving bodies. So that means the decomposition must be halted. We all know that when death occurs, the body is colonized by putrefaction bacteria and other microorganisms. So by removing water and fat from the tissue and replacing it with polymers, deprives the bacteria of what they need to survive. But the body fluids and the fat in the body cannot be directly replaced by polymers. So it requires two stages. In the first fluid exchange stage, the water and the fatty tissue are replaced by acetone. That is an intermediary agent. And in the second stage, in the forced vacuum impregnation, this acetone is replaced with a polymer solution. So that is the principle of plastination. So water and fat are removed by the intermediary solvent, and then intermediary solvent is later replaced by the polymer. The steps involved in plastination are fixation, dehydration, forced impregnation, and curing. So any convenient method of fixation can be used. A caseling solution can be added to the fixative to enhance color preservation. And organs removed at autopsy can be fixed by immersion. And fixation can be omitted if epoxy resin plastination is intended. Next stage will be the dehydration. So dehydration and defatting are mandatory since water and lipids cannot be exchanged directly with polymers. So there are two methods are used. One is the stepwise dehydration in graded alcohol, and the next other method is the freeze substitution with acetone at minus 25 degrees centigrade. So before we start dehydration, it is important to pre-cool the specimens at plus 4 degrees or 5 degrees centigrade. So what is the advantage of doing advantage of doing ethanol dehydration? We all know that ethanol the stepwise dehydration in ethanol, it is similar to what we use for histology preparations. So here the advantage is that embalmed specimens can be used because in plastination the long chain alcohols in the embalmed fluid is not good. So when we use ethanol, so that will be taken care of by it, and then you can dehydrate at room temperature and the specimens can be stored at 70 degrees Celsius. But the disadvantage is that it causes considerable shrinkage and it is time consuming. And also, this is not an intermediary agent. So after the dehydration with ethanol, then this ethanol has to be replaced by the intermediary solvent, that is the acetone. But about the freeze substitution with acetone at minus 25 degrees Celsius, actually there is no actual disadvantage. It saves time. Acetone serves both as a dehydrating agent and an intermediary agent, so it requires less labor and the amount of shrinkage results is very less. So in freeze substitution, at least 3 changes of acetone are needed. To start off with, we'll start with the 85% of acetone, and then we'll give some 2 or 3 changes in 100% acetone. So the volume of acetone to be used should be 5 to 10 times the volume of the specimen. Usually it takes around 6 weeks time. And dehydration should be measured by the equipment known as the acetonometer. So we have to constantly check the amount of water that has been replaced with this instrument, acetonometer. Then defatting. In freeze substitution, defatting requires an additional acetone bath at a room temperature. If the specimens are very highly lipid-rich specimens, and then it needs a final bath of methylene chloride also. So here we are saying that initially minimum 3 changes of acetone in minus 25 degrees centigrade, and after that it has to be kept in room temperature for at least 2 or 3 days so that the defatting has to be completed. For plastination, whether to use acetone or methylene chloride is again an intermediary agent. But acetone is the best one because it acts both as a dehydration agent, degreasing agent, and an intermediary solvent. Now coming to the third step, that is the forced impregnation. That is the central and most important step in impregnation, in plastination. So here, the specimen soaked in acetone are replaced with, we have to, once the specimen is taken out from the dehydration and degreasing is over, then we should aim for the impregnation. So the acetone, the specimen soaked in acetone is placed in the polymer solution. The polymer solution has a high boiling point, whereas the intermediary solution has a low boiling point. So what happens is when vacuum is applied, only the intermediary solvent is continuously extracted out of the specimen. It escapes through the surrounding polymer. So we can see bubbles coming out of the specimen. So once the acetone, as the acetone is being extracted, the polymer solution slowly permeates into the tissue. So this process is allowed to continue until all the tissue has been completely saturated. The surrounding tissue is also whatever the acetone which is oozed out in the resin, that also will be lately evaporated. So the amount of polymer what we used will be very minimal, approximately to the volume of the specimen only. So this is a vacuum chamber. Here we need then a vacuum pump to which will be connected to the vacuum chamber, and this is then a vacuum one air valve. So here the speed of the impregnation is very important. So the vacuum chamber has a glass door on top. So we can see the amount of a bubble which is coming out. So the amount of bubble which is coming out can be adjusted using this air valve. And then as the when the bubble stops coming, then we know that the impregnation is completed and the specimen can be taken out of the vacuum chamber. The polymers with a higher viscosity require a longer impregnation time than the polymers of a lower viscosity. And even if the specimen is larger and denser, then impregnation time will take a longer time. The advantage of forced impregnation is polymer is not diluted by the volatile intermediary solvent, as this is extracted continuously extracted out. So the polymer can be reused. The quantity of polymer used is also very small, and forced impregnation results in fast impregnation and it will be complete, and the speed of impregnation can be adjusted. So the forced impregnation can be carried out either at room temperature or in deep freezer. But at all cost, we should avoid a rapid extraction of the intermediary solvent because it will result in shrinkage. The final stage is the curing or hardening. So it depends on what type of resin we are using. If you are using S10, then the curing is by gas. If you are using polyester, then it is by the UV light. And if you are using epoxy, then the curing is by the heat. So these are the 4 stages of plastination. Fixation, dehydration in minus 25 degree of acetone, and forced impregnation using a vacuum, and then curing. So these are the 4 steps of plastination. There are different types of plastination. It can be classified depending on the type of resin we are using: silicone plastination, epoxy plastination, and polyester plastination. And it can be again classified into whole organ plastination and sheet plastination. For whole organ plastination, we'll be using silicone, and for sheet plastination, we can use either epoxy plastination or polyester plastination. So coming to the silicone plastination, so the steps involved are same. It's like fixation, dehydration with acetone at minus 25 degree, forced impregnation, and curing. So the specimens fixed in formalin are washed in running water and pre-cooled at 4 degrees centigrade. So that we'll keep the specimens in running water for about 12 hours, and then we'll wrap it in a cling paper and keep it in the fridge at 4 degrees centigrade. Then the specimen is kept in a container containing 85% acetone in the deep freezer. So the water content is checked often. So when we check, if the water content remains same for consecutively for 3 days, and then we'll change it to the next batch of acetone that is in 100% of acetone. At least 3 changes should be done. For the initial stage, we'll use the used acetone from our previous plastination method, and then only at the final stage a new acetone will be used. So after dehydration, when it reaches around 99 or 98%, the specimens are taken out and kept again at 4 degrees centigrade for a day, and then defatting will be done in acetone at room temperature. So if the acetone becomes very yellowish or something, and then we'll again replace it in a new acetone. Otherwise, we can straight away take it for impregnation. So for forced impregnation, the polymer which we use in our institution is from Biodur. So Biodur S10 100 parts and S3 1 part. So S3 acts as a hardener. So forced impregnation is done at room temperature. So impregnation is determined to be complete when the acetone bubbles are no longer released from the specimen. The quantity of polymer consumed again will be very small, and it will be almost equal to the volume of the specimen. So the next stage is the curing. So for a silicon plastination, the gas curing is the method. So S6 is the solvent. So here, this is our gas curing chamber. So this is just an aluminum box. So here, this is the S6. We have kept it. This is the stock solution, which is kept in a small bottle. It is connected to a membranous pump. This is an ordinary aquarium pump where we'll get it from any shop. So it is connected to that. And here there is a fan. This actually, when the membranous pump is switched on, this liquid will be converted into a gas, and there will be a continuous circulation of S6 within the aluminum box. So for a uniform distribution, that fan is will switch on the fan also. And here there is a filter paper. And then on that we have kept the specimens. So once we take the specimen from the vacuum chamber, it should be wiped off, and then we have to keep it in the gas chamber, and the box should be completely sealed off. And during the first day of a curing, at every 1 hour or 2 hours, we have to open the box and we have to wipe off the specimens again and again. Maybe after the second day or something, there will be we can see it once in 4 hours or something like that. But on the first day, every 1 or 2 hours, we have to repeatedly clean the specimens. Otherwise, the silicone will be embedded into the specimen and it will spoil it. And one more thing during gas curing is actually we have to fix the specimen how do we want. It's like especially for hollow organs. It's like a stomach or intestines or anything. That lumen has to be plugged. Then only we'll get the shape of the organ. Otherwise, the lumen will be collapsed. If artery or anything, it has to be, the lumen should be filled with some tissue paper, and then we have to plastinate. We have to do the curing. Curing is the stage, whatever position you want the specimen to be, it has to be adjusted in that stage. It's very important. One disadvantage of doing the gas curing is it is like a white segmentation can be deposited. So we should not expose the specimens too long in S6. And even we can put some calcium chloride crystals in the aluminum box, so that will prevent the humidity. And once that oozing of the polymer is stopped, the specimens are taken out, and it has to be kept in one plastic container or a plastic bag which is tightly sealed for another 2 to 3 weeks. So final curing is finished when the specimen has been dried to touch for a couple of days. So next is like this plastinates can be made lighter by adding xylene into the polymer mixture. We used to add 1:3 ratio of xylene with the polymer mixture. So the xylene molecules are smaller than the silicon molecules. When that acetone is extracted out, easily the xylene molecules will go and fill the space which is created by the vacuum than the polymer. Later that xylene evaporates and that space will be filled by the air. So that is the principle in lightweight plastination. So these are some of the S10 plastinates which are made in our department. Next is color plastination. It is like for better differentiation, we used to color the arteries, vein, nerve, etc. It can be colored after plastination also, but the drawback is it is like often it will be peeled off. So there's a process called, it is like, we can color the structures, whatever artery, vein or a nerve, and then plastinate. Actually, it can withstand the plastination. The what are the chemicals used and how to use is given in this paper. So you can read this paper. Anyway, I have given this one. So these are the different reagents. And for different colors, it is like we have to add the reagents in this order. So the details you can see in the paper which has been published. So this is our color plastinate. So this is like arteries are colored red and fibrous skeleton are colored with green. So these are the ligaments of the foot. It has been colored green, and this is the nerves and vein of the arm, artery. All these are colored with blue, yellow, and red. So this will sustain the whole plastination technique, and they are permanent. Next is our polyester plastination. So polyester plastination utilizes polyester resin P40 for producing high quality brain slices with good gray and white contrast. Polyester resin plastination can be used for body slices also. This also follows the same principles of plastination, fixation, dehydration, forced impregnation, and curing. So brain slices of a desired thickness is like usually 4 to 6 mm is cut using the brain cutting machine. We can cut the brain with our brain cutting knife also, but the drawback will be we cannot cut very thin slices using the brain knife, and also that the the slices won't be uniform throughout. At one end it will be more thick, and the other end it will be thin like that. So brain cutting machine is very useful one, where we can use cut thin sections. 4 to 6 millimeter can be cut with a uniform caliber, and the diameter and the slices should be stacked and then kept in running water, pre-cooled and dehydrated in acetone at minus 25 degrees centigrade, and then it has to be impregnated in P40. It is advisable to keep the brain slices in P40 overnight in the dark before the commencement of impregnation. So this allows the brain slices, acetone and resin to equilibrate. Next is like, so here the degreasing is not needed in polyester plastination. So when this impregnation is completed, we have to make a flat chamber or it is called the casting chamber. So how to prepare this casting chamber? We need 2 glass plates of equal size, and we need a silicone gasket, and we need some clamps. So the 2 gas plates are kept together, separated by the silicone gasket. So it will go around the glass plates, and here if you notice, the one end will be shorter, the silicone gasket, and the other end we leave a long end, so that later it can be joined with this short one. And then we have to clamp it along with the silicone gasket inside. So the chamber is formed, it should be tightly sealed, there should not be any gap. And then we can pour the P40 through a flat funnel. So here that this chamber is being filled with the polymer, and then we have to insert the brain specimen into it. So once the specimen is inserted, then this one, the long end of the silicone gasket is brought to the shorter end. It is sealed by a sealant. So one of the tips is like, actually we can before we seal it, we can put some 1 or 2 ball bearings here, with the help of a magnet from outside the glass. Actually, if we can move it, actually because of a slight displacement of the polymer, we can position the brain tissue in place. We can center it, or when we take it from here to the curing chamber, if the position change, you can readjust it with the help of this ball bearing and the magnet. And one important thing here is like there should not be any air trapped in the resin. If at all any air is trapped, we can put some 1 millimeter thin wire into it and bring it to the top of the chamber. because if the air is there, and then that final outcome will not be a good one. So then this is a gas curing sorry, this is the UV curing chamber. So for polyester plastination, we use the UV curing chamber. So these are some of the P40 plastinated specimens. So here we can notice that good white and gray differentiation can be seen. So once the curing is over, then we can dismantle the flat chamber, and the silicon tube and the glass plates and everything we can reuse it again. So what is the use of P40 plastination? So we can use it for making good brain slices to show the gray and white differentiation. So they make an excellent teaching aid, especially for teaching cross-sectional anatomy. And the amount of resin used also will be very less. And the P40 impregnation can be used if we keep it in dark and in cool place. We can use it for many years. Next is our E12 sheet plastination. In our institution, we still haven't done E12 plastination, but the principle is the same. So it involves the epoxy resin impregnation of thin, it's like a 2 to 4 millimeter or ultra thin sections. So we can get thin transparent plastinates. So they are good for histology because they can be easily dissolved by sodium methylate. So preparation of the specimens. So here again, that a very thin specimen should be cut. So that is cut with the help of a diamond knife bandsaw. And here both the fresh and fixed specimen tissue can be used. For if we intend for epoxy plastination, we can skip the fixation step also. And the dehydration is done by acetone. And then the impregnation, this is the combination of the chemicals epoxy, E12, E1 and E600 hardener and the accelerator. So the mixture is reactive and it is temperature sensitive. So once it has been mixed, actually that impregnation has to be done quite fast, and curing will be done in a gas chamber, sorry, in a heat chamber. It's done at 40 degrees centigrade. So this is one of the sheet plastinate. Next is the equipment, materials and safety protocols required for different types of plastination techniques. So in our institution, we have this two freezer. This is minus 85 degree and minus 25 degree, and this is the vacuum chamber. So when we started our plastination technique, so that time the one more step was there. The specimens, after from pre-cooling, it was short frozen at minus 85 degrees centigrade, but because of the specimens may break, so this step is now completely omitted. So now what we actually need is a minus 25 freezer, and this is our vacuum chamber. But for a vacuum chamber, the locally available our desiccator can even be used as the vacuum chamber. It has to be connected with the vacuum tube and the vacuum pump. And this is the valve which helps to adjust the amount of vacuum what we apply. And these are the polyethylene buckets. We need a lot of this because this will be used for the dehydration, for keeping it in the vacuum chamber and all this. So these polyethylene buckets are needed, and acetonometer is very important to assess the dehydration of the specimens. And as I said, this is our gas curing chamber. It is an indigenously made aluminum box which contains the fan and the aquarium pump. And the amount of acetone used in plastination is very high because we use it as a dehydrating agent, intermediary agent, a defatting agent. So that amount of acetone we are using is very high. So we have installed an acetone distillation plant. So as I said, for that initial stages of plastination, we can use this acetone. 85% and even for 100% acetone, we can use the distilled one. And the last step, we are using the new acetone which we buy from the commercially. And things needed for P40 plastination, this is a sorting mesh. So thin slices are taken, so they are stacked using this sorting machine, and this is the brain cutting machine, and this is the UV curing chamber. And for making the flat chamber, so we need 2 glass plates, we need the silicone gasket, and we need this clamps in addition to the sealant. So if we are planning to do an epoxy resin to cut thin sections, bandsaw with diamond knife is needed, and also a heat chamber is needed because curing is done at 40 degrees Celsius. So what are the safety protocols? Because we keep the specimens for dehydration, we use the minus 25 degrees Celsius. Hand gloves made of polyvinyl chloride is very important. Goggles is important. Acetone, the aiming point of acetone is 19 degrees Celsius. So any source of inflammation, sparks and flames should be kept off. No smoking in the plastination lab. And acetone container should be labeled flammable, or the symbol should be put off. And during dehydration, the container should be lightly closed with the lid, because if by any chance there is a power cut or that freezer stop to work or anything, then the acetone should be warm, and then it shouldn't burst. So that always we close the container lightly. And when we use E1 epoxy resin, if at all we are using E1, this epoxy is, the reports have said that it will cause allergy. So we have to put a full apron also if at all we are using epoxy plastination. And when we mix E1, that exhaust system should be there in the lab. So to summarize the things needed for plastination, so any type of plastination, deep freezer at minus 25 degrees is important, acetonometer is important, and vacuum chamber, vacuum adjustment valve, vacuum tubing, vacuum pump, and gasket is important. If you are using polyester, silicone plastination, gas curing chamber is needed. But if you are using polyester plastination P40, and then we need an UV curing chamber. Other than that, it is like polyethylene buckets, sorting mesh, glass plates, silicone gasket, paper clips are needed. And for the protective mechanism, the hand gloves made of polyvinyl chloride and the goggles are needed. So what is the application of a plastination in medical education, research, and healthcare? So as we said earlier, plastinates are dry and robust, and the students will love to handle the specimens. And we can also take the specimens out of the dissection hall to go and teach to other classes or anything. So to lecture room, we can take it and we can demonstrate. We can use that for the small group teaching. So it is a very useful teaching tool. So here you can see our students are handling the plastinates to learn some brain specimens, to do the cell array and all those things we can learn. And these are some of the cross sections which are made in our department, and very useful for teaching cross-sectional anatomy. So we have labeled all the cross sections. So they can, with the cross section and the labeled picture, they can compare and they can learn cross-sectional anatomy. So this is the P40 plastinates. So P40 plastinates, and then we have an overlay. All things are labeled, so they can compare and they can study. So corresponding MRIs also will be put up, so they can see the section and they can compare with the CT or MRI pictures. It is very useful for teaching ultrasound anatomy of the heart. So this is a parasternal view, and this is the apical view. So if you see, it is like you can see some chambers only, but which chamber is what? So here, so we have made all cuts of um, uh, our heart specimen. So here you can see this is a left atrium, so this is the left atrium, and this is the left ventricle here. So this is the left ventricle, and this is the outflow tract, left outflow tract, and this is the right ventricle. So this is the right ventricle. So they can correlate the specimen with the images or with the ultrasound. So it will be very easy for the students to orient themselves to ultrasound, CT, MRI, etc. And they make a very excellent museum specimens also. So in our museum, we have a lot of museum specimens mounted and plastinate specimens mounted for museum. And you can use this plastinates for conducting our spotter test. So all exams, okay, we needn't take out all the wet specimens. We can easily conduct spotter test using the plastinates. And coming to the research, in our institution, we have some papers related with Eastern plastination, lightweight plastination, color plastination, and deplastination, etc. Now, actually, epoxy resin is playing a major role in research. Nowadays, for many papers are coming. It's a collaborative work between anatomist and the radiologist, and they are doing lot of studies on joints using, and they can reconstruct the plastinate image, the plastinates with MR images, and they are doing a lot of studies on joints. So this is one of the study which is done using plastinates in sacroiliac joint specimens. Nowadays, the latest thing is facial anatomy. So many anatomists are showing interest in facial anatomy. So epoxy resins are used to study the facial structures in the body. And in India, actually, so what I have told is that in our institution, we are using biodegradable products, but in India, there are a lot of indigenous resins are being used, and there are many papers which are coming out using the different polymers which are using in India. So these are all various avenues for research. And coming to healthcare, actually, these plastinates make an excellent tool for patient education. In our department, we have actually made some plastinates to clinical departments, and they are using it to explain to the patients about the diseases, the surgeries, etc. In a very understandable way. They are teaching them to the patients. So it makes an excellent tool for patient education, and is for exhibition. It is like we conduct an exhibition once earlier before the corpora. We used to conduct regularly. So we use all specimens, but the plastinates are very easy because once we keep it, that exhibition goes around for a week. So we needn't take it out and keep it out from the tanks and everything. So it's very easy to arrange for the exhibitions. Otherwise, the wet specimens every day morning it has to come out from the tank and it has to go in, and then in between it has to be wetted and all those things. But the plastinates and even the students, they love to handle also. They'll handle the specimens and they learn. So they'll form very useful for conducting exhibitions, to teach about the anatomy and healthcare and anything. So they'll form an excellent tool for healthcare also. So next is the limitation of plastination. So plastination techniques are good for medical education, but anyhow it cannot replace our dissection. So it can be used only as an adjunct of our dissection teaching. And the plastination technique requires trained personnel, And also it is time consuming because at least minimum of 3 months is needed to prepare one plastinate. If you want to get a good plastinate, the main thing is that preparation of the plastinate, I mean specimen. All the fascia and tissue, everything has to be neatly dissected out, then only we can get a good plastinate specimen. So if we are replacing the plastinate specimens for our dissection, and the students will lose the skill of a dissection. And also the feeling of that wet texture also will be lost. So in summary, plastination technique, the principle is replacing the water and the fat in the body and replace it with the polymer. It takes in 2 steps. The first step, it is the water and the fat are removed and replaced by acetone, which is an intermediary agent, which is compatible with both water and the polymer. Later, this acetone is replaced by polymer. So it takes 4 steps. It's like a fixation, dehydration, degreasing, and then forced impregnation and curing. We have different curing for different polymers we are using. So if you are using silicone, it is the gas curing. If it is polyester, it is UV curing. And if it is epoxy resin, and then it is by heat we are curing it. So it can be, the plastinates make an excellent tool for medical education, and we can do a lot of, opens up a research avenue, and it can be used to improve the healthcare also. And plastination, though it is a very good thing, it has its own limitations. So these are my references. So once again, I thank the audience for your patience listening, and for the organizers to give me a chance to do this. Thank you.
Thank you so much, ma'am, for your well-informative lecture that has enhanced your depth of understanding the art of plastination. Thank you, ma'am. Now the topic is open for discussion. Delegates, you can post your questions in the chat box if you have any. So questions, shall we wind up the session, ma'am, if there are no questions?
Okay, thank you.
Thank you, ma'am.
This S10 and P40, we are getting it from Biodur. It is in Germany. Coming to the cost, it is like, see, the cost will be, initially it will be little more. It is, I think, around 1 lakh for 50 liters of S10. But we've got S10 50 liters 10 years ago. And still we have leftovers, and we have plastinated many organs. Because that amount of polymer used is very less. It is like, and we can reuse it again and again and again if we keep it at minus 25 degrees Celsius. We can use it again and again and again. So, and also now with that introduction of lightweight plastination, adding xylene to the polymer, so that polymer which we are using now is what we got some 10 years ago. We got it for around, at that time, for 1 lakh we got it. So the plastination lab setup also only that initial investment is the thing. It is like a one minus 25 degrees Celsius freezer and one vacuum pump. If you are intend to do small specimens only, and then we can use the small desiccator only. So other than that, nothing else. I mean, the major things are needed. Um, the setup actually we can run it for now. We are running it almost for more than 15 years without any change of equipments or anything. To set up the lab, as I said, only things what we need is a minus 25-degree freezer and a vacuum chamber. That's the main thing what we need. Other things we can use whatever is locally available, we can use it. The next question, can we use liquid silicon rubber? Actually, I don't have an experience with it. Can the brain cutting machine be used for sections of brainstem also? Yes, of course. We can use it for brainstem also. Okay, thank you.
Thank you, ma'am. Kindly accept the memento and the certificate for the session as a token of gratitude, ma'am.
Thank you.
Now, I invite Dr. Kumaran sir, Associate Professor, Officer in Charge, Department of Forensic Medicine and Toxicology, JIPMA Karaikal, to introduce our next speaker, Dr. S.B. Ray sir.
Good afternoon, all. It's a privilege for me to invite our next speaker, Dr. S.B. Ray sir. Sir is currently the professor in the Department of Anatomy, AIMS, New Delhi. He has a vast teaching experience of 30 plus years of teaching undergraduate and postgraduate students. His main area of research is neuropharmacology and pain modulation. Sir has published more than 50 scientific publications in national and international journals. Sir has achieved many awards. Notable things are AIMS Excellent in Research Award, Best Teacher Award, Tulsibai Somni Award for Best Oral Presentation, ICMR International Fellowship Award, AIMS Infosys Endowment Fund Award. And Sir also holds a patent in National Patent for Analgesic Preparation containing morphine and nimodipine in 2004. And I welcome you, sir. I request sir to enlighten us on the topic, Thawing the Potential of Cryopreservation, a Revolution in Science. Thank you, sir. We welcome you, sir.
Can you hear me?
Yes, sir.
Okay, and the screen is also visible?
Yes, sir.
Okay. Okay. Good afternoon to one and all. In the beginning, I want to thank Dr. Sharanya and her team for inviting me to this very informative CME. The title of my talk is Thawing the Potential of Cryopreservation, and I will leave it to the audience to judge the relevance of this with regard to medical science. So these are the learning objectives for this presentation. I will first discuss the benefits of cryopreservation in artificial reproductive techniques. I will define cryopreservation as a storage of cells and tissues at ultra-low temperatures without damage. Identify ice crystal formation as the major deterrent during cryopreservation. Recognize that cryoprotective agents prevent ice crystal formation or at least reduce them to a significant level. Classify cryopreservation into slow freezing and vitrification methods mainly. Describe recent advances in cryopreservation with reference to organ transplantation. And finally, appraisal of limitations of the cryopreservation. So first I bring to your attention a case study where there was a live birth from frozen embryo. This was reported in 2014 in the journal Human Reproduction. And I will just give a very briefly, the patient was an ovarian cancer patient, and initially her right ovary was removed and for papillary carcinoma, and the left ovary was, there were a few cysts in it. And then the left ovary later, after 9 months, the left ovary also developed carcinoma, and the left ovary also had to be removed. So after that, when the left ovary was removed, the physicians, they took out the oocytes from there, and they from the left ovary, and they in vitro matured the oocytes. And later on, when her chemotherapy session was over, she was implanted with the embryo. So the embryo, the oocytes were recovered, they were matured, and then through IVF, from her partner, the embryo was there. And then the embryo was, when her chemotherapy session was over, the embryo was implanted into her uterus, and there was this was the first pregnancy and live birth resulting from cryopreserved embryo. So I want to bring to your attention another case study, which was which became a very important news item. This was in December 2016, where a lady has baby using ovary frozen in childhood. So I will just give you some of the details of this so that it becomes clear. So Mausa Matrosi from Dubai was born with thalassemia. When she was 9 years old in 2001, her right ovary was removed and cryopreserved. Later on, the chemotherapy with bone marrow transplantation was done. And when she recovered at 24 years, the preserved ovarian tissue was transplanted on the left ovary. Now, because of chemotherapy, the left ovary was dead and she had gone into menopause. So strips of the ovarian, right ovarian tissue, which was preserved, about 4 strips were there, they had recovered, and the 3 strips were implanted on the left ovary, and one of the strips was implanted on the uterus. And her fertility was restored, and her hormonal status became normal from menopausal state. And so before her so the right ovary was removed, and the ovarian cryopreservation was done. Later, the ovary was transplanted when she was 24 years of age. And from there, the embryo through IVF, the embryo was produced, and she had a successful pregnancy with delivery. So when we look at the overall in the New England Journal of Medicine, there are various options for preservation of fertility in women. And one of them, this was published in 2005. One is the cryopreservation of oocytes and embryos, and which I have told about in case study 1. And the other is the ovary is removed and cryopreserved. And then the ovary itself can be transplanted later on in the next session. I also want to bring to your attention a very interesting paper published in Nature Medicine in April 2022. This work was done on laboratory mice, but it holds implications for humans also. Pancreatic islet cryopreservation was done from one set of mice and also from other mammals, including humans. And these were xenotransplanted and also transplanted allotropically onto other mice. And the authors have said that these islets of Langerhans continue to produce insulin till about 5 months. So this was but it has not been reported in human. Human islets were taken and transplanted in mice, and they continue to work there. So that was the point of the study. So in future, we have some hope for patients of type 1 diabetes. So it has been said by Confucius that to know the future, we should look into the past. So here I will give you a history of cryopreservation. So it was in 1776 that first an Italian called Lazzaro Spallanzini, he observed under the microscope that animalcules, there was no name for parasites, etc. So and bacteria. So animalcules could be observed in decaying food, and he used the recently discovered microscope from Leeuwenhoek Hawk. He also reported observing animalcules in seminal fluid from different species. And he also noted that these spermatozoa could survive low temperatures and not heat. So this had a very important of importance here, because later on Louis Pasteur took up this data and he invented the process of pasteurization. So in 1842, a patent was issued in Britain for freezing food in a mixture of ice and salt brine. The temperature can go down to minus 37 degrees centigrade. Then in 1866, Paul Mantagazza, he demonstrated that sperms when frozen could survive for days. And later on in 1901, Jacobus van 't Hoff, a Dutch chemist, exposed mammalian cells to hypertonic solutions and showed that almost 80% of the cell is water. So because normally on an average, about 55 to 60% of the cell is water. So when you freeze the cell, there is ice crystals will be formed. And it has been observed that initially ice crystals are formed in the extracellular space, and later on they are formed in the intracellular space. The ice crystals have jagged ends, and these jagged ends can damage the cell membranes and intracellular organelles. Ice crystals also cause the remaining cytoplasm and extracellular fluid to become concentrated with a higher osmotic pressure, and it draws out the water from inside the cell, making them dehydrated. Now, up to a certain level, the cell can collapse and the cell membrane can spring back. But after a stage, the the cell membrane is permanently damaged and the cell is not able to recover and it dies. So freezing is fatal for human tissues. So, but here we are using freezing to preserve human tissues for long periods of time. So, if I want to define cryopreservation, cryopreservation is related to use of low temperatures for preserving cells and composite tissues, but not organs. Organ preservation is at a nascent stage now. So cells and tissues for long periods of time. Now, cryopreservation and cryobiology are different terms. When we talk about cryobiology, I have already mentioned that ice formation related to osmotic stress, related to physical injury, these can damage the cells. So cryobiology is the preservation of the cells and tissues in the living condition with minimum damage. So, and this becomes very important because a large part of the cell is water. So Van Hoff made a factor plot for which he received the first Nobel Prize in chemistry in 1901 for demonstrating this fact. Now, in 1938, a technique of cryopreservation called vitrification was discovered. And it was invented by a gentleman called Basil Lewitt using frog spermatozoa. And what he did was he exposed to hypertonic sucrose solution followed by freezing. Sucrose is a cryopreservative. I'll talk more about it later. And then in 1942, human spermatozoa was vitrified, that was frozen without damage by Hudson Hogland and Gregory Pincus. A very important chapter opened in 1949 when this group of Christopher Polgy, Audrey Smith, and Alan Parkes, they discovered that glycerol as a cryoprotectant. So cryoprotectant is an agent which prevents ice injury. How does it prevent ice injury? It binds to the hydrogen bonds of water and prevents the water molecules from freezing, by forming ice. And in the process, it decreases the freezing point of water. It also increases the viscosity of the solution. And many of the cryoprotectants are able to pass through the cell membrane, like DMSO, like glycerol, and they are able to protect the cytoplasm from the cell in the cytoplasm, the water in the cytoplasm from freezing. Now, there is something of anatomy over here, which anatomists routinely do here. Now, I will just move away from this and show you the next slide. Now, what happened was this discovery of glycerol as a cryoprotective agent was by serendipity. Serendipity means that you start out with something and you get something else. Now, the frog spermatozoa, the scientists, the Polgy group wanted to store in D-fructose. Actually, that time it was called, more commonly called levulose. And they thought they had preserved the spermatozoa in levulose solution. They were experimenting with different chemicals as a cryoprotective agent. So they found a bottle in the freeze which was labeled D-levulose. But actually, that bottle was not D-levulose. It contains what we commonly use for smearing slides, that is Mayer's albumin, which contains a lot of glycerol. So they had misidentified the bottle and they had put the specimen in Mayer's albumin solution. So later on, they were not able to reproduce their result. So then they thought, what happened? Why we are not able to repeat the result? So they did a chemical examination of the solution, which was labeled as levulose, and they found actually that it contained glycerol in large amount, and that is how glycerol was found out to be a cryoprotective agent. In 1952, the first calf born from frozen thawed sperm by artificial insemination. And Burns and Sherman reported first human baby born from frozen sperm of deceased father. This was the first case which was reported in 1953. Thereafter, in 1959, dimethyl sulfoxide was found as a very good protectant. And 1984, the first successful birth from frozen embryo, that is an IVF technique, is a landmark event in the field of artificial reproductive technology. So this was reported in 1984. And currently, integration of cryopreservation techniques are going on with stem cell therapy and also for organ transplantation. Organ transplantation, you'd know that for a heart to be removed from a donor and to be put into a recipient, there is only 4 to 6 hours. And for a kidney, there is 8 to 10 hours or 12 hours. So the donor and the time for transportation taken for transporting the donor organ to the recipient organ at between 4 to 6 degrees, that is the norm now, transporting at 4 to 6 degrees centigrade. It is very difficult, and according to Western estimates, almost 60% of the transplant organs are lost due to this transport. So if we can use cryopreservation technique for preserving the transplant organ recovered from the recipient, then it would be a path-breaking discovery in medicine. So before I go on to the proper topic, I want to bring your attention to a condition called freeze tolerance. The freeze tolerance is seen in amphibians, reptiles, certain insects and fishes in the Arctic region. They can be frozen for months. Their heartbeat will stop, their lungs will not function, and after 6 months to 8 months, they come back to life. There, you can see over here, the lens is also whitish in color as it is frozen. So this wood frog is found in Arctic region and Siberia, and this is the Rana sylvatica. Now what happens is, just in the autumn months, it starts synthesizing a lot of glycogen in the liver. And this, as the frog starts freezing, the liver starts breaking down that glycogen to glucose, which through a temporary increase in the heart rate, the heart rate is almost 8 times increased, it is delivered to the different organs of the body. Now, glucose is a cryoprotectant, preventing damage to the cells when the rat is frozen. In addition to this, the cell membranes in this organism is protected by synthesis of additional phospholipids by different enzymes. Like one is the steroyl coenzyme desaturase, which is called the SCD, which hardens the cell membrane and prevents them from collapsing when the frog has frozen. In addition, there are ice-binding proteins like FR10, which prevents ice crystals from becoming large. So when the ice crystals become large, they damage the cells and the tissues. So if something can be there to prevent the ice crystals from becoming large, then it will be a very useful thing. But as of now, synthesizing these ice-binding proteins and using them for human organ preservation is prohibitively expensive. So this has been observed that this can't be implemented. So in this stage, the frog can remain for almost 8 months before it recovers. So this freeze tolerance is a very important phenomenon, and scientists have picked up a lot of information from these animals. Now I want to tell you that when water freezes and forms crystals, many of the larger solute particles are driven out from the crystal. And what this causes is a hypertonic solution in the remaining extracellular and the intracellular space. And the remaining hypertonic solution now starts drawing out water from the cells. So when the water is drawn out from the cells membrane tend to collapse and it also gets dehydrated. So this is called the solution effect when freezing of water happens. The nucleation effect is when after freezing, when the freezing has been done and the ice crystals are small or negligible. Now, when the thawing of the tissue occurs, then what happens is these small ice crystals act as nuclei for formation of larger ice crystals. So even during thawing also the tissue may be lost. The third thing is that oxidative stress. Now, what in the previous slide I have told you, this frog starts anaerobic glycolysis. It stops the aerobic glycolysis because it will require more oxygen, and it starts the anaerobic glycolysis in the frozen state. So when there is thawing, lot of oxygen is used by the cells, and they produce oxidative stress. To counter that, this frog synthesizes lot of antioxidative reactive oxygen to neutralize the reactive oxygen species. These are the mechanisms by which so oxidative stress is an important feature in cryopreservation. Now let us look at this. This I have taken from a journal. So if you look at a cell and we say that we want to cool it, we want to freeze it, then as the temperature drops, you can see ice crystals are forming on the outside. Now, when these ice crystals are forming and there is a slow cooling, the ice crystals will draw out the water and the cell membrane will collapse. This is the solution effect. Now, when we do a rapid cooling, then there are chances that ice crystals will form very quickly in the inside. And this can be prevented by using the cryoprotective agents. So if we now look at optimal cooling, then in the optimal cooling, when we use both vitrification and the cryopreservation, vitrification is rapid cooling in steps. So when we use the cryoprotective agents, then not much extracellular ice is allowed to form. And this is through vitrification. And no intracellular crystals develop because I will say no extracellular, I will say that minimum extracellular crystals develop and minimum intracellular crystals develop. So there is some damage to the cell, but the cell can recover after the cell is thawed and then cultured for implantation. So depending upon the situation, the tissue is thawed and the tissue can be then devitrification and can be used. Now, using for vitrification, we need high concentrations of the cryoprotective agents, and the cryoprotective agents can themselves cause toxicity if they are allowed to remain in the tissue while the tissue is being transplanted, while the tissue is being implanted. So the cryoprotective agents have to be removed before the tissue or the biomaterials are transplanted back. So there are problems in with the cryopreservation technique, and I will now try to tell you about what exactly is cryopreservation. Maintain biological samples at very low temperatures. So what is the temperature that we are talking about? Minus 80 degrees centigrade to minus 196 degrees centigrade. I want to make a difference here, according to the scientists, that up to minus 80 degrees centigrade, it is called freezing. while below minus 80 degrees centigrade to minus 196 degrees centigrade, which is the temperature of liquid nitrogen, it is called cryopreservation. So biological time is suspended when the tissue is cryopreserved. So the state of suspended animation. Then it can be stored for considerable periods of time. You have seen that in the case studies that I have pointed out, that they have been stored for years. And the fourth point, and the most important point, that you can store them, but you have to ensure also that the cellular structure does not get damaged while thawing and whether and when it is being implanted by removal of the cryoprotective agents. So let us see what the temperature does to the tissues as we do the cryopreservation. Between 0 to minus 25 degrees centigrade, enzymatic activity is active but slow. It is there till minus 25 degrees centigrade. Minus 40 degrees centigrade, physicochemical activity completely ceases. And at minus 130 degrees centigrade, preservation of tissue can be done for long periods of time. Now, some scientists would like to dip the tissue in liquid nitrogen. While maintaining liquid nitrogen in large amounts is expensive. So the other option, and also liquid nitrogen has some pathogens at times, and some cancerous cells also at times if the previous tissue is from some cancer patient. So if there are, immersing in liquid nitrogen, many of the scientists feel it is not a good option. So they expose the tissue to the vapor of liquid nitrogen. So that is how minus 130 degrees centigrade temperature is preferred here. So cryoprotectants, cryobiology, as I told you, the difference between cryopreservation and cryobiology was born in 1949 with the discovery of glycerol by serendipity. Main action of cryoprotective agent is to protect from damage due to ice crystal formation in biological samples to the extent possible. We cannot totally prevent it, but we can minimize it, make the ice crystals very small. There are several mechanisms of action of cryoprotective agents. I have already mentioned it disrupts the hydrogen bonds in water molecules. It lowers the freezing point of water, and it also stabilizes the cellular structures. It helps in stabilization of the phospholipids in the cell membrane, and there are a few other mechanisms of action. And when we talk about the classification of cryoprotectants, there are two types of cryoprotectants. One is the diffusible, which can pass through the cell membrane, like glycerol, DMSO, ethylene glycol. By the way, ethylene glycol is the antifreeze agent used in the cooling medium of automobiles when they are used in the very cold climate. So ethylene glycol is also used in the industry. And non-diffusible, like sucrose, all those of you who do immunohistochemistry, you know the value of sucrose in cryopreservation. Also hydroxyethyl starch and a double glucose compound called trehalose, which is synthesized by insects. This trehalose is used now for cryopreservation or cryopreservation procedures. So what is the procedure of cryopreservation? Sample collection, preparation of cryoprotective agent, then sample processing, where you mix the sample with the cryoprotective agent. So if you are thinking what is the concentration used, then for DMSO, it is 5 to 10% of DMSO is used. But if you need to do vitrification, that is very rapid cooling in liquid nitrogen, then the DMSO concentration has to increase to almost 40 to 50%. And this is why the DMSO becomes toxic at that high level when the tissue is thawed. Now, there are two processes. One is controlled freezing and one is vitrification. I will tell about this more later. And then it is stored in liquid nitrogen, or it is stored in a very low temperature machine. And it can be stored there for days to years. And then it is thawed, and then the tissue is taken out. It is assessed. It is usually, we have procedures for biomaterials like cells and composite tissues like blood vessels are very resistant to damage. So common carotid artery, etc., for artery transplant, split thickness skin grafts are very endure cryopreservation very well. Cartilage, bone, and then when we look at the cells, then stem cells can be, and bone marrow cells, these can be cryopreserved very efficiently. So these cells are then evaluated for their longevity and for recovery, and then they are implanted into the patient. So these two are key processes. It is not the storage. It is when the tissue is being freezed and when the tissue is being thawed. These are the two steps where damage occurs. So these two are very critical steps in cryopreservation. So techniques of cryopreservation, one is slow freezing. That is number one technique. Then this came in first. So gradual cooling minimizes ice crystal formation. And you can use the cryoprotective agent over here, without which it is not be possible. The second is vitrification. Now, what is vitrification? Vitrification is not allowing ice to form by freezing the tissue at a very high rate, somewhere like 1000 degrees centigrade per minute or even more. And what happens is, instead of freezing in high amounts of CPA, the water forms it does not form a crystalline structure. It forms an amorphous structure, a glass-like, it transfers into a glass-like state, non-crystalline amorphous structure. And this is one of the preservation methods. This is specifically called vitrification. And the third is where it is totally liquid nitrogen is used here. And the third is where there is a controlled rate freezing. A machine is used to bring down the temperature, and then it is transferred to liquid nitrogen for storage. So it is costly, requires sophisticated instrument, while these two are relatively easier methods. Now, what are the differences between slow freezing and vitrification? And I leave you to find out which one would one prefer. So slow freezing is gradually lowering the temperature of biomaterial at a controlled rate, and vitrification is ultra-rapid cooling, which converts the intracellular water into a glass-like state without formation of ice crystals. The cryoprotective agent protects from intracellular ice crystal formation. I have told you about the mechanism of action of the cryoprotective agents. The here the concentration can be very low, like 5 to 10%, but here the cryoprotective agent concentration needs to be high, almost 50%. So, but we need to understand that when we are preserving the oocyte, or we are preserving the embryo, then the total amount may be in microliters, and it is taken in a straw and it is dipped into liquid nitrogen. So, because the CPA is very high, so there is chance of toxicity. The third is slow freezing. There is formation of extracellular ice, which has to be controlled by the CPA. And in this, because high CPA has been used, so there is toxicity, and also from liquid nitrogen itself, there may be pathogenic contamination. So nowadays they have sealed tubes in many centers, so that the biomaterial does not come directly in contact with the liquid nitrogen. And there is an intermediate temperature cryopreservation. I told this before, that cooling between temperatures to -80 to -150 degrees centigrade, it eliminates expensive liquid nitrogen storage, and ice crystal formation is reduced compared to slow freezing method, and cells may not survive as well as in liquid nitrogen immersion. So there are these are the advantages of each method, and it is upon the scientist or the embryologist who is using these techniques. So once again, so for slow freezing and vitrification, concentration is low of CPA, high here. Risk of toxicity is low here, high here, and working time is more than 3 hours. And here working time, it is in less than 10 minutes, the vitrification is done. So manipulation skill is easy, it is difficult. Post-thaw viability is high in both cases. Risk of ice crystal formation is high in slow freezing, while it is low in vitrification. Potential contamination with pathogenic agents is low in slow freezing, but it is high in vitrification. So, so all these points have to be considered. So what all we can do? Actually, cryopreservation is a transformative technology. It can store biomaterials like bone marrow, stem cells, etc. It can also be useful in agriculture. It is also useful for maintaining biodiversity for plants and animals which are getting extinct. So preservation of cells and tissues like sperms, oocytes, embryo, stem cells, cell lines, microorganisms, tissues like skin graft, blood vessels, bone marrow, cartilage, and periosteum, and nowadays even cornea and nerve allografts. That means when it is implanted into a different person. And it is seen that when the tissue is cryopreserved, there is some decreased antigenicity of the tissue. So the tissue is the chances of the recipient accepting the material becomes little higher. I have already mentioned this. So next slide. What are the limitations of cryopreservation? So cold-associated changes in lipids and protein resulting in impairment of cellular activity. It is true even that the success of IVF will be more, and ICSI will be more in fresh embryo than in cryopreserved embryo. But large number of women, particularly in the Western countries, they are opting for delayed pregnancy, and even without any medical issue. And that is why cryopreservation is coming up, particularly in Western countries, very much. So CPA itself can cause damage, and it has been seen that they can damage the DNA, they can damage the epigenetic mechanisms, etc. And of course, I have mentioned this before. So what is cryonics? Now, I want to bring your attention to this Captain America. It's a Marvel comic hero. And this person was frozen for 7 months in the Arctic ice before he was revived, and he was supposed to fight with the evil forces, etc. So the cryonics has derived the inspiration from here. It is still in the stage of science fiction. So what exactly it is? Life after death by cryopreservation. So people are freezing the dead bodies in the hope that one day the science will be developed so much that the dead can be brought back to the living. So process of cryopreservation should start as soon as possible after death, within minutes. So the staff members are there to take care, and what they do in very brief, it involves dehydration, flushing with cryoprotectant, cooling on ice before immersing in liquid nitrogen. Now, what would be the approximate price for this? So it will be about US $2,000, which will roughly translate into just over 1 crore rupees in Indian currency. So people who are would be interested in cryonics, they have to really be very rich to be able to afford it. And these are some of the firms which do this procedure, like Alcor, Cryonics Institute, and TransTime. So there is a ray of hope on the horizon for cryopreservation of organs. This paper was published. Still now, organs cannot be cryopreserved. It is because there are different tissues in the organ, and they have different freezing rates and thawing rates. And basically, it has to be uniform so that the entire process is done in a uniform manner. But because organs itself are made of different tissues and they have different sets of freezing and thawing points, so and also the cryoprotective agent is not able to penetrate each and every part of the tissue successfully. So till now, it's a dream, not a reality. But this paper from scientists in the University of Minnesota in USA, published in 2023, worked on the rat kidney, and they perfused the rat kidney with the iron nanoparticles. Nanoparticles are very small particles, less than 100 nanometers in size. So when they isolated the kidney, they perfused it with the cryoprotective agent dissolved in the saline, and they also infused it in iron nanoparticles into it. And then they treated the kidney. They stored the kidney in minus 150 degrees centigrade, which causes the kidney to vitrify, entering a glass-like state, which is less damaging to living cells and crystalline ice. Now, the thawing is a problem, as I mentioned earlier. So what they did was, when they wanted to thaw the kidney, they put the kidney in a magnetic coil, and the magnetic coil flipped orientation literally 360,000 times per second. So what happened was, these iron nanoparticles, they produce some thermal energy, and that thermal energy progressively thawed the kidney, and the kidney could be brought back to the body temperature. And then this kidney was flushed to remove the iron particles and other CPA, etc. And then it was reimplanted into another rat. And when it was reimplanted into another rat, they saw that this kidney continued to function for more than 30 days. So this is a very, very important paper in the current literature, which gives us some hope that organs in the future can also be cryopreserved. I end my talk by just showing this picture. Currently, the Ban Divas is going on, and for the preservation of environment, and you can see so many children and adults. They are planting the small plants in their neighborhood. So this Ban Divas will go on till 15th of July, and I request everyone to take part in this one Divas, so that our environment is preserved. Thank you very much for your patient hearing.
Thank you so much, sir, for your insightful and extensive lecture. We are grateful for sharing your expertise with us, sir. Thank you, sir.
Thank you very much.
Sir, there are some questions in the chat box. Sorry. Participants, if you have any queries, you may please post your questions in the chat box.
Yeah, no questions. So.
Yes, sir. What would be the approximate cost?
It should be expensive. It should be cryopreservation of biomaterials would be quite expensive. If I give a rough estimate, for cryopreservation of embryos, etc., it may be between 4 to 5 lakhs. 4 to 5 lakhs. And apart from that, the medical charges, etc., will be separate.
Thank you, sir.
And
So kindly accept our token of gratitude, memento and the certificate of your presentation, sir. Thank you, sir.
Thank you very much. Thank you.
Now we have come to the end of the session. Distinguished guests, esteemed speakers, delegates, and all the participants of the CME, as we conclude this enlightening CME on journey of anatomical gift, procurement to ultimate utilization, I'd like to extend my heartfelt gratitude to each one of you for making this program a resounding success. First and foremost, I would like to thank the Almighty for guiding us throughout this journey. Next, I would like to express my sincere gratitude to our director, Dr. Virsing Sir Negi, for his unwavering support and encouragement, which made this program possible today. I would also extend my heartfelt thanks to our Dean, Dr. Kusakumar Saha, for his invaluable guidance and support, which has been instrumental in the success of the CME. Additionally, I thank Sir for actively participating as a panel member and enriching our discussion. I would like to extend my special thanks to our esteemed speakers, Dr. Sudha Seshan Madam from Saksa University, Dr. S.B. Rao Sir from AIMS New Delhi, Dr. Navita Agarwal from AIMS Bathinda, Dr. Suganti Rabi Madam and Dr. Deepak Francis Vinod Sir from CMC Vellore, Dr. Sunil Subramaniam Sir from Pondicherry Institute of Medical Sciences, and last but not the least, Dr. Rajshekhar Sir from Jupmer Puducherry. Sir was the main pillar for the conduct of the CME. Thank you all the esteemed speakers who readily accepted this talk and enriched our knowledge by sharing their expertise. A special thanks to Dr. Vidya for efficiently moderating the panel discussion. To all the delegates, I extend my sincere gratitude for your patience and dedication, attentively listening to the sessions over the past 2 days. Behind the scenes, the backbone of this program has been our IT team led by Dr. Vignesh, officer in charge of IT team, who has taken all the necessary measures to ensure smooth running of this program. Special thanks to Mr. Arvind, Junior Administrative Assistant, Mr. Manikandan, Networking Operation Engineer, who has worked tirelessly to make this event a grand success. And also our special thanks to Mr. Vinayagam, Audio Technician, who has given his expert technical assistance to the program. I would like to extend my gratitude to Dr. Sarasu Ma'am, Professor and Head Anatomy, Jupmer Puducherry, for her valuable support when we are short-staffed with only 2 faculty in our department. Madam has paired the senior residents from Jupmer Puducherry on rotation on their requirement, in spite of their requirements in the Pondicherry campus. I really thank Madam for the help and support that she has given us throughout the postings. Dr. Sara Madam, Additional Professor and Head at Anatomy of AIMS Madurai, and Dr. Aparna Muralidharan, Associate Professor of Anatomy, Pondicherry Institute of Medical Sciences, are special members to receive our gratitude for their valuable inputs and contribution to the conduct of the CME. Additionally, I thank all my UG and PG teachers of anatomy, especially Dr. Ratnasamy sir and Dr. Ramadevi madam, for their inspiration, guidance and valuable lessons I learned from them. A special thanks to our other organizing team members, our organizing vice chairperson Dr. Vijay Kishan, organizing secretary Dr. Kumaran and joint organizing secretary Dr. Shivakumar, and other organizing team members Dr. Ambiga and Dr. Gomati and Dr. Georgina George, senior residents of Jipar. I sincerely thank our Associate Dean Dr. Balamurugan sir and Academic in charge Dr. Jaykumari madam, Dr. Subhash sir, officer in charge of outsource wing, and all the housekeeping staff who has helped us to run the show. I also thank our great pillars, student volunteers, Anusha, Mr. Abir, Mr. Patan, Mr. Sam and Mr. Firoz. They are first year MBBS students of batch 2024 and the entire batch of 2024 for their support and cooperation for the conduct of this event. All the officer in charges and faculty of Jipmer Karaikal and our registered Dr. Lieutenant Commander Rajkumar sir, they have helped us in facilitating the smooth conduct of this program. Finally, from the bottom of my heart, I thank every one of you who has made this CME a grand success. Thank you all once again for your grand participation in making this event a success. Thank you. There were There were some questions in the chat box yesterday and today. I hope we addressed most of the questions. In spite if there are any pending questions to be addressed, we will compile all of the questions and the explanations from the speakers, and we will share the information through email or WhatsApp. Thank you all. We end the session. Thank you.
Thank you very much.
If there is someone who is willing to share the experience, we would like to stay back to hear from them.
Yes, definitely.
How we will know?
They themselves will start open the mic. They have to speak.
Make everyone unmute.
If anyone wants to speak about the program, they can put in the chat box. We will unmute them. I think we are not having anyone in the chat box. So we thank everyone for joining us in this CME. So we are ending
Dr.
the...
Taslima.
Okay. Dr. Tulasima. Taslima, madam. You can unmute. Madam, you can unmute yourself and you can speak if you wish to speak. Yes, madam, you can. Madam?
I'm very grateful for the organizers. It was a wonderful, enlightening session from your side. And only when we try to do practically all these things, very, very meticulous points we got from the CME. The CME was very, 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 very enlightening, especially Dr. Rajshekar sir. Sir, very, very enlightening your points were right from the speaker one, Dr. Vijay Kishan, Dr. Saranya, and everyone's talk. Valuable points we could get for our practical
Madam, you can
purposes,
switch on the
especially
video.
ma'am.
Madam, you can switch on the video, please.
No, sir. Actually, I
Okay,
couldn't
madam.
switch
Okay, madam,
on the
please.
video. Madam session on bone retrieval and very practical points we got, and most of our doubts could be clarified from the CME. The selection of topic was very, very nice, plus the speakers. So the speakers were, the authenticity of the content of this program was very, very nice. Beautifully it was executed. Even the panel discussion was so well organized. Most of the time in many CMEs, we won't stay through the panel discussion, but here we couldn't leave. The questions were very beautifully selected and it was very beautifully executed. From very institute like this, it was like very, very, very authenticated content we could get. So we are very pleased with this, the content and the authenticity of the speakers as well. Thank you very much. And we are looking forward for future CMEs from your side.
Thank you, madam.
Thank you,
madam.
Anyone else wants to pass the comment? Yes. So we thank everyone for joining us in the CME program, and we are ending the session now.
Thank you.
Thank you.
Thank you.
Thank you.